Very good morning to all of you. So we would be starting this session with Dr. Partha Pratim Pan. He is professor in North Bengal Medical College and Hospital, and he would be talking on role of PRP therapy in PMR. Dr. Pan, please.
Hello. Yeah.
May I request the control person to start the clock when he starts talking?
Sir, shall I start now?
Yeah, start please.
Okay. So, pranam and very good morning. I'm Professor Partha Pratim Pan. I'll talk on platelet-rich plasma in PMR and all P. And my journey will be from a pessimism to positivism. And the very important studies, two important studies, that's PEAK trial and RESTORE trial, they showed that platelet-rich plasma is nothing. It don't work than normal saline, particularly in osteoarthritis of the knee. And depending upon these two trials, US FDA have not yet approved PRP in osteoarthritis or any musculoskeletal condition apart from intraoperative use. But who is US FDA to approve platelet-rich plasma? Because it's not a drug at all. It's your autologous blood collected and the platelets is taken out from it. And number two, what is your experience? Yes, it cannot reverse complete joint damage and even replace the surgery, particularly in complete joint tear and ligamental tears, complete ligamental and muscle tears. So I'm starting my journey from a perfectly negative baseline, not zero. I'm negative baseline. What is PRP? It's a preparation of, you all know it, it's a preparation of autologous plasma, usually containing between 2 to 7-fold of platelet concentration that normally contain in the whole blood. And are all the PRP same? The techniques used to generate platelet concentration product differ in amount of whole blood, type of anticoagulant, number of spins of centrifugation, time and speed of centrifugation, and the final volume and the number of platelet in the platelet concentration. This number of platelet in the concentration is very much important, and further studies showed that the evidence, not only experience, the evidence showed that the PEAK trial and the RESTORE trial, which I started with, they had only 1 billion, they delivered only 1 billion platelet in the joint. But the studies showed that there should be at least 5 to 10 billion platelets in the joint to act properly. So the number of platelet is very much important. And platelets are actually they come from the megakaryocytes in the bone marrow, and they're unnucleated, and they're the first cell type to arrive at the site of tissue injury, particularly in the early inflammatory phase of the healing process. They play a role in homeostasis through cell membrane adherence, aggregation, clot formation, and release of substance that promote tissue repair, angiogenesis, and control inflammation. PRP may affect soft tissue healing via growth factors released after platelet activation and degranulation, and there are alpha granules and delta granules. Alpha granules contain platelet-derived growth factor, transforming growth factor beta, epithelial growth factor, fibrinogen, fibronectin, vitronectin, and delta granules contains other chemicals like serotonin, histamine, dopamine, calcium, adenosine. Almost 30 products have released from the activated platelets. And what they do, these growth factors, they help to repair and angiogenesis and ultimately tissue healing. I'm not going to detail. So platelet activation takes place. We have to give some time within few days after injection, triggering the release of significant quantities of growth factors. The process ultimately leads to symptomatic improvement, and most people notice the definitive improvement by 4 weeks. And there are varieties of preparation of PRP. Some contains pure platelet-rich plasma, some leukocyte and PRP, some pure platelet-rich fibrin, and leukocyte and platelet-rich fibrin. Last two are mostly used in dentistry. But we use PRP, and that is also two types. One is leukocyte-rich PRP that includes enrichment of WBC and more inflammatory, used in tendon and muscle injuries. And leukocyte-poor plasma, generation 2 PRP, that has low WBC, is less inflammatory and potentially more beneficial in avascular applications like joints and discs. And these are the phases of repair, inflammation, proliferation, and remodeling, and platelet is active help in initial 2 phases, inflammation and proliferation phases, and also some part in remodeling phases also. So this is the scientific basis of PRP, how it acts. So how it is prepared. We prepared it by centrifuging autologous anticoagulant whole blood to separate components and concentrate platelets above the baseline level. This is the machine we use, and we use 2 spins platelet, two spins. First spin is called soft spin. It's an 1800 revolution per minute, and second spin 3200 revolution per minute. And the plasma in what we get it from the plasma in the lightest phase in the top, and in the lowest, if the highest volume weight is of RBC, they in the down, and in between the Buffy coat, and in the Buffy coat, ideally, we are in after second spin, after proper concentration, in the Buffy coat, the platelet concentration is above in the higher side, in the top side on the Buffy coat itself, and leukocyte granules in the lower side. So this is the mechanism of preparation. This is the process of preparation. And application of PRP is in almost in all field of medical science, and therapeutic application is many gynecological and reproductive medicines, urogenital application, or dermatological applications, and in aesthetic, some reconstructive breast surgery, vulval reconstruction, and definitely in hair. The most well-used, as much as we use botulinum toxin to reduce spasticity, botulinum serotoxin is more used in aesthetic use. So similarly, PRP is, the story is same for the PRP. What are the use in musculoskeletal medicine? Then shoulder injuries, in rotator cuff tear, and different ligamental injuries and slap lesion, in elbow lateral and medial epicondylitis, in back and hip facet joint arthropathies, SI joint arthropathy, and wrist and hand decoherence disease, in knee, osteoarthritis, meniscal tears, and all ligamental tears, and an ankle and foot, plantar fasciitis, and Achilles tendinitis. So I'm just overviewing some studies which have shown the different studies and case control studies, double-blind studies, systemic meta-analysis, which showed that PRP injections have a role in osteoarthritis. First, I'm giving importance to osteoarthritis, and it in inflammatory, these inflammatory markers is reduced in the significant decrease in the inflammatory markers. This study showed after giving PRP in osteoarthritis joint, and intra-articular PRP helps in knee, early to moderate knee osteoarthritis and also severe knee osteoarthritis, and it can be the second line of treatment after non-pharmacological treatment, pharmacological and oral drugs and non-pharmacological treatment, because that it slowed the progression of arthritis. It has shown that after 5 years study, after giving 3 platelets, it slowed the progression of arthritis in 50% of patients. So, and another important thing is, it's the studies showed it has definite beneficial effect over intra-articular hyaluronic acid and definitely a steroid injection. So, because PRP has, helps to change the biochemistry of the arthritic joint, and it can at least delay the need for knee replacement surgery. But one important thing that studies have not, though we sometimes use, but the studies has not shown any superiority of combining hyaluronic acid and PRP therapy. So, and another important thing is that very much hyped thing, that is stem cell therapy, that does not show any beneficial result, more beneficial result than PRP. Both are same in result, and definitely you know that cost effectively PRP is more cost effective. And these are many more studies, I'm not going details. And these are the studies in epicondylitis that we usually give methylprednisolone or triamcinolone in epicondylitis. But PRP, not in short term, but in long term, do definitely better result, give definitely better result without doing any harm, which that steroid can do in epicondylitis and any other decoherence disease, plantar fasciitis, Achilles tendinitis, all these soft tissue cases. And definitely in shoulder rotator cuff injury, there is a good role in PRP, this study showed. And also in our, we deal with diabetic foot ulcers, and PRP therapy, it can be given in injection form or in topical application, and few weekly injections or applications will help to recover the diabetic foot. So now I'm concentrating on role of meniscal injury. In meniscal injury, there are many more many factors. Platelet-derived growth factors help into repair, and there are many studies which showed the meniscal injury healed with platelet PRP, and intraoperative PRP, which has already approved, has with operation intraoperative PRP has a definite role. And these are different types of meniscal tears. These are MRI findings, and these are MRI grading of grade 1 and grade 2, grade 3 meniscal tear. We particularly used 10 cases of meniscal, we studied 10 cases of medial meniscal injury in the Department of PMR. We got the first of its kind machine in West Bengal, and we formulated a study, and patient between 18 to 35 with medial meniscal injury, traumatic, not degenerative, and no associated OA, and injury not more than 6 months, and we given injections, and we studied the outcome of NRS scale and Oxford knee scale. We give the injections like this, and by ultrasound guidance. And 1 to 3 points that cortisone should not be given with it, and no lignocaine, because they alter the pH, and heat can be applied, that it can increase the cell signaling, and NSAIDs should be discontinued 2 weeks before and 4 weeks after, because it is antiplatelet agent. And after injection in meniscal tear, there should be graded rehabilitation protocol, and the results we saw in 6 weeks and 3 months, and we got in both NRS scale and Oxford scale, we got significant result. So we are, this is not a study, this is only some cases we have shown, and we are going to plan some case control study and in-depth studies in different grades of meniscal tear. So I could got crowned the platelet and completed my journey. I could not completed, started the journey from a pessimism to positivism. Pranam.
Thank you, Dr. Pan. Any comments, queries from the audience?
Yeah. Hi, Jay.
Please provide a mic in the audience.
No, definitely. The market PAP, I don't have any personal experience, and I think it may cause some side effect because it is not autologous. In our cases, and all the studies showed that is mild symptomatic pain, or in some few cases that is with acute inflammatory reaction for few days, but after that everything subsides with rest and rehabilitation. But autologous, markets PRP, I don't have any experience. I think it may cause some reaction, allergic reaction, all these things. And number two is that the studies showed, and our experience is definitely PRP definitely works. And there are many MRI findings after 6 months. We have not done any MRI findings because we do in a government hospital. It's not that we have not that opportunity to do plenty of MRI. But the MRI findings in various studies showed the definite improvement after 6 months of therapy. Thank you, sir.
Consultant in R.N. Tagore Hospital, Kolkata. And today she will be talking about role of virtual reality in balance rehabilitation in patients with spinal cord injury. Dr. Sen Gupta, please.
Good morning, sir. Should I start? Okay. A very good morning to everyone. An absolute pleasure to be on this stage and also to share the platform with some of my favorite speakers. I'm going to talk about the role of virtual reality in balance training in patients with spinal cord injury through the looking glass of a study, which was my postdoctoral thesis during fellowship days at NIMHANS. This is dedicated to my guru, late Professor Dr. Ambar Ballab. Now, balance is the key to everything in life. How can the body be an exception? So how do you get a balanced body? It is through the coordination and the integration of the senses, the visual, vestibular, proprioceptive feedback, and the reflexive limb control. Now, patients in spinal cord injury have got that dissociation. They cannot integrate it that way. So they need to undergo balance rehabilitation to determine the key determinants of ambulation, which is balance, strength, muscle tone, and proprioception. Now, when I talk about balance, there are two kinds of balance. One is the static and the other is dynamic. The static balance helps you with the postural stability to do your day-to-day activity. And what is dynamic balance? It prevents you from falling. So basically, when you're walking, it's a series of gait cycles which are preventing you from falling. So that is dynamic balance. So before I move further, let's see if this video plays, and then I'm going to tell more about VR.
Left. By another, wait.
See, there is a patient.
Right side.
And there is a therapist behind the patient. And if you see carefully, there is a screen with a representation on the screen and a camera below that.
Left.
Okay. So this is the crux of VR. What happens? you are forming an interaction with the virtual environment, and you are forming a kind of real life scenario. So there is a camera which is capturing your image in whatever form and gives you an avatar on the screen. Now when you get feedbacks, like the therapist was saying, you move to your right and you move to your left, you follow your avatar, you manipulate your avatar and do certain activities. So this is the basic crux. So what is VR? It's an advanced form of human-computer interaction, and it allows users to become immersed within synthetic computer-generated virtual environment, simulates real-life scenario, and multimodal cues are provided, and the user will manipulate the object, and they receive instant feedback. So whether that is visual, audio, or haptic. I'll come into details. Depending on the extent of the user's isolation from the surrounding, during an interaction, you can divide VR into 3 ways: immersive, non-immersive, and semi-immersive. So immersive is, see the lady is wearing something like a headgear that is called the head-mounted device, where you're completely immersed into that environment. So for example, it's a construction work going on. It's a 3-dimensional issue. You are inside that construction work, and you do not have any idea with the surrounding outside. Semi-immersive is where there is a 3-dimensional image. However, you are not completely isolated from the surrounding. There is an avatar which you are manipulating, which is somewhat like the video I showed. And non-immersive is, it's more like video games, where it's a 2-dimensional image. So over the last 10, or I would say 15 years, there's been plenty of VR application in different areas of clinical medicine. Who's this lady? Anybody? Okay, she's the actress Radhika Apte. Why I put this is from the movie Phobia. And this was my first interaction with VR, and this lady had agoraphobia. So she was given head-mounted device where she was trained to shop inside a supermarket, and so that she could face the real world. So this was interesting considering the age at which this movie was made. Coming to the study proper, this is a prospective, comparative, matched pre-post study done at Department of NR at NIMHANS, September to May 2017 and 18, with a sample size of 33, under the guidance of Professor Dr. Anupam Gupta. We included spinal cord injuries, both traumatic, non-traumatic, between 18 to 60 years, less than 6 months, all kind of AIS, with a single insult, with NLI C5 or below, and the ability to abduct both shoulders at 90 degrees. This was purely so that they could perform in the games. And we excluded those with severe visual, cognitive, orthopedic, or progressive non-traumatic SCI. So we hypothesized that with the VR, the balance and, of the trunk and the postural stability should improve. So with that hypothesis, our aims were to evaluate the effects of a game-based VR training program for trunk postural control and balance, compare balance with a matched control group of SCI patients, and to assess whether motor completeness or incompleteness has any relationship with this. So the system that we used was a semi-immersive one called the Rhetoric, made by a Spanish company. So if you look at the picture, again, there is a camera. That's an infrared camera which captures the image, and the gentleman has an avatar on the screen. So the camera has a depth sensor as well as a motion sensor. Now you have to regulate the identical body part of your avatar. For example, you want to move your hand to the right, you stretch it out like this. You want to catch a ball, you hold it like this. And this is a picture of the Microsoft Kinect, which is a motion sensing input device for the Xbox, which is the key factor in this system. So 25 patients met our inclusion criteria. After the dropout, we got 21 patients in our experimental group. This experimental group got 15 sessions of VR therapy along with conventional therapy. Then the participants' demographic characteristics were stratified, and we divided them into 12 subcategories. Then we got 12 matched controls who were also spinal cord injuries, each representing one subcategory, and then they received conventional therapy alone. And what were the matching criteria? The NLI, cervical, upper thoracic, lower thoracic, etiology, severity of injury, whether it's motor complete or incomplete. We grouped them as group 1 and 2, and age categorized per decade. So to put it simply, let's say a 25-year-old traumatic spinal cord injury of Asia C was paired with, let's say, a 29-year-old traumatic spinal cord injury, Asia D. Okay, so this is how the matching was done. This was the gross matching criteria. So the experimental group received VR sessions, 30 minutes each, 5 days a week for 3 weeks. And if you see carefully, here, okay, that's me 6 years and 6 kgs younger. So there was a physiatrist who was regulating the entire session, and that physiatrist was me. There was a therapist, but the therapist was mostly for supportive. And what about blinding? The patients did not know about the outcome measures, and the initial and last assessment was done by a person who was blinded, whether the patient received VR or not. Okay, so these are the games we included, like focusing on trunk control and bimanual coordination, dynamic balance, etc. And few things about the games. So initially we started with very simple games. Now once the patient could perform at least 80% of these games, we automatically upgraded them to a difficult level. What do you mean by difficult level? Maybe the stimulus was faster, or the angulation was more acute, greater joint excursion needed. So we just kept making it difficult on a patient-to-patient basis. So the outcome measures were Berg Balance Scale, the balance section of the Trinity Performance-Oriented Mobility, and Functional Read Score. What is FRS? It is either you abduct your shoulder to 90 degree or this forward flexion to 90 degree, and then you reach out to catch the object. The distance that you have covered, that is your score. The average of that is your Functional Read Score. Okay, so the statistical analysis was done by our software, and we compared the experimental and the control group, and there was no statistical difference. So it was a good comparable group. Now, when we compared the experimental group and the control group at pre and post therapy, we found that statistically significant improvement was seen in both the groups. Okay? However, when we compared with the completeness of the injury, there also we did not see much difference except a few things. Like in AIS C and D, in the experimental group, we found a steeper curve in the Berg Balance Scale, and in case of POMA-B, we found a score, a p-value of 0.016. So the advantages and disadvantages, the participants were more responsive, and they had the liberty to undergo training in any position. Any kind of neck pain, back pain that the patient has was also taken care of with the training. We did not come across much side effects. There was some orthostatic hypotension, which was manageable conservatively. So there are a lot of theories and mechanisms of actions of VR. Now, I have summarized them through multiple literature. One is, of course, the neuroplasticity. Any task-based approach is going to cause neural reorganization, motor relearning. It has been seen that there is dynamic structural brain plasticity when you see through spectroscopy. And what happens is when you're reaching out for a virtual object, probably the excursion of your joint is more. So the proprioceptive feedback is more. Again, your center of gravity is moving beyond your base of support. So you're challenging your body more. And this also leads to proprioceptive and neuromuscular stimulation, leading to muscle relearning. There are theories that it activates the mirror neuron system, prefrontal cortex, and parietal cortical area. There was a study where the hemodynamic aspects were studied in healthy objects using VR, and the oxygenation in PFC was found to be higher with functional infrared spectroscopy. And because you're giving a multimodal sensory stimulus, there's a lot of neural bombing at the damaged spinal cord. So these are grossly the mechanism on which you can explain how VR works. Now, you might ask, we also had motor complete SCI, then how come they improved, okay? These are our theories. 2 of the AIS-As had actually converted to AIS-C, and we had more of sensory sparing than motor sensory sparing, so the proprioceptive sensation might have helped. And we are not sure, there might be a lot of discomplete spinal cord injury, because now a lot of literature is there between complete spinal cord injury and discomplete spinal cord injury, where you can go for tractography, spectroscopy-based studies, and sensory-evoked studies to see maybe the tracts are intact. Now, what are the advantages of a conventional training? You can manipulate, fine-tune, it's engrossing, motivating, and it can be combined with other technology. That's me with HMD at IIT Chennai. I was the first volunteer for their HMD. So the limitations of the study, sorry, one slide I think I've missed here. So what did we conclude from that study? That VR, we did not find it to be superior to conventional study, But however, considering the limitation and the increasing trend of activity, it might have more positive results based on certain factors, which are our study was not randomized, it had small sample size, the long-term effect could not be assessed. At the time we did the study, there were no guidelines, no Indian studies available, and we are not sure whether our software was technologically advanced. There are better software available now. Now, coming to a bit of literature, this is one of the earliest studies and extremely well cited, where a VR was used in paraplegic spinal cord injury and compared with non-disabled people for a feasibility study. You know, in 3 different atmospheres or virtual environments, the sitting balance was measured. Again, while we were doing the study at NIMHANS, this article came out. Probably this is the first Indian one. It came from Delhi that virtual reality game-based training is better in improving balance and functional performance in individuals with paraplegia than real-world task-specific balance training. They used reach test and skim, etc. So even in our study, actually, we had used HADS, skim, and other parameters, but for the publication purpose, we stuck only to the balance parameters. Now, this is a very interesting study where 12 spinal cord injury patients, can I take a minute?
Eating into interactive time.
I think I'll quickly finish it. So they were used for driving. And this is a newer study where force-sensitive application was used to measure the sitting balance. This is what I mean by haptic sensors. This is again a study where, you know, improvements 4 weeks post-training were measured. So VR has been single for a long time. VR mingles with BCI, FES, body weight supported treadmill training, and finds a good marriage in robotics. So a lot of systemic studies are, meta-analysis is coming out on this. We see there's a paradigm shift from earlier it was considered inconclusive, then COVID came, it was considered useful. Now it's more towards mostly promising, probably good when you look into systemic reviews. Our study was published in Asian Spinal Journal. This is another study we published, a case report with VR. And this is my current department of PMR and Neurorehab in Kolkata. It's just 2 months old. Please come to Kolkata, bless the baby, and give me suggestions. Thank you.
Thank you, Dr. Madhushri. Now there is time for a few queries or comments.
Thank you. Sir, I don't remember that. Probably Dr. Anupam Gupta will be able to say, because the instrument, I think it is somewhere in 4-5 lakhs. Something between 2 to 5 lakhs, I'm not sure. Gaurav, do you know the cost? We'll find it out, sir. Yes,
Yeah.
sir. Sir, please. Yes. Yes. Thank you, sir. This is a very good question. There are a lot of theories on that probably you're putting the patient in a more virtual environment. It's not as real life as it is claimed to be. Again, see, if I go by our study purely, then I cannot comment, because we did not find any noticeable difference. Also, most of the studies on VR are with very small population size, 15, 20, 30. Long-term studies are hardly there. Just one study I think I mentioned where 4 months post-study they had seen, and where they found that the results were sustained. So frankly, I cannot say for sure, but yeah, I mean, if it is done consistently or periodically, it should remain. But then, of course, conventional rehab cannot be eliminated. That has to be there.
Thank you, Dr. Madhushri, for your presentation.
Thank you, sir.
And now I call Dr. Sindhu Vijay Kumar. She is Associate Professor of PMR in Amla Institute of Medical Sciences, one of my former colleagues at AIIMS New Delhi. And she has worked in Canada also, and she would be talking on evidence-based use of assisted devices. Dr. Sindhu.
Thank you, Dr. Gogia. Good morning to all of you. It is an immense pleasure to be here, and I thank the organizers for giving me this opportunity. As opposed to my previous two speakers, a topic on assistive devices, it's not a single topic. Probably it's a heterogeneous mix of so many topics, and that's probably what I want to conclude by the end of this presentation. My objective was that the listeners should be able to have a basic understanding of the nature of evidence, especially the high quality evidence about the assistive device use, list maybe at least 5 broad areas of research in assistive technology going forward from today, and just a quick glance at the WHO priority assistive products list, as well as the national list of essential assistive products developed by the ICMR. They've had a panel discussion yesterday, and I've missed it. All listeners may initiate some steps. This is my hope, to create evidence for it to use in our own practice. We need some things for us. The outline, I'll be discussing a bit of the literature search and showcase some of the evidences. I'll be presenting a few very interesting articles from different research aspects or different views at research. The lists summarize, and if time allows, I would propose a classification system. I've looked at the guidelines and recommendations, so mainly searched for the keywords assistive technology, assistive device, evidence-based, and rehabilitation. So I've got 16 documents from IAPMRCON, EBRSR, NICE, and Cochrane reviews, PubMed research, again, many articles, but then I have handpicked 28 articles. Scopus and Web of Science did not really yield anything. Just a quick glance. I'm sure we all know the levels of evidence, the hierarchy, and the recommendations. So the actual guidelines where I could, so there is no guideline for assistive technology use in IAPMRCON if you use it. Like IAPMRCON is the evidence-based review of acquired brain injury, moderate to severe acquired brain injury. So the guideline says, in the topic of assessment of assistive technology, individuals with traumatic brain injury should be assessed to determine whether equipment or adaptations could increase the safety, independence, communication, as well as quality of life. It should be conducted by professionals who are proficient in the use. And key is it should be on an individual basis, it should be in the environment in which it is going to be used. Again, some things that we forget sometimes in daily practice. A lot of recommendations for the prescription of assistive technology, the key points being take into consideration the cognitive, communicative, and behavioral deficits of persons. It should be provided as quickly as possible. It should not be delayed. Should be trained, person as well as the caregiver, the family, should be trained in the use of safe as well as effective use of the equipment. Clear written information for repairs, replacements, and future help, which is interesting. Have timely provision of an appropriate wheelchair and suitable supportive seating package. Again, something that we almost never give, the seating system. Walking or standing aids after a full assessment of the potential benefits as well as harms that for a cognitively impaired person, it may prove to be more harmful than useful. Then evidence was present in basically module 20 and module 18, which are dealing with cognitive communication as well as learning and memory deficits. So talked about text-to-speech technology, offering a level 4 evidence. Virtual reality, I'll completely skip. We've had an excellent presentation before me. Voice organizers, micro-prompting, palm-top computers, PDAs. I think most of it are now replaced by the smartphones now. The IAPMRCON guidelines are actually were reviewed in 2022, I guess. Again, text message prompts, computer-based software programs, VRs. I now move on to, sorry about that, evidence-based review of stroke rehabilitation, the 19th edition, the EBRSR. These two evidences, these two resources, ARAB and ABRSR. I think we all must go through their excellent practice guidelines and give a very comprehensive management strategies for us. Talks about a NETA Uni wheelchair, which is a single upper arm controlled wheelchair with a shift. So there is only one rim and maneuvering that can go to both sides. Cycle ergometer training, virtual reality, and defector training. It says mixed literature regarding the effect on functional ambulation and muscle strength. And defector assisted gait training may be helpful in improving functional mobility, but may not be beneficial for improving balance and activities of daily living. Exoskeleton systems may not be beneficial is the recommendation from EBRSR. FES may be beneficial. Arm-shoulder effector robotics, mixed evidence. Exoskeleton, again, upper limb exoskeleton, mixed evidence. So, as you see, this is only regarding ATs, and there are many other guidelines available. From the National Clinical Guidelines for Stroke, people with limited mobility after stroke should be assessed for, provided with, and trained to use appropriate mobility aids, including a wheelchair, to enable safe, independent mobility. Cochrane reviews, many reviews, again, most of the studies, they've looked at many randomized controlled trials, but most of them no conclusive evidence or low quality evidence. And what they report is that all the RCTs have low methodological criteria. So that was kind of depressing because that was the first few things that I looked at. And after having 95 randomized clinical trials and then saying there is no evidence, and it is concerning, right? NICE guidelines, again, use of equipment, kind of on the similar lines as the IRAB as well as EBRSR. PubMed research review, impossible to cover in this topic, in this presentation. So a few important studies, translation of evidence-based assistive technologies into stroke rehabilitation from users' perspectives. In this study, interviews were conducted for both healthcare professionals and patients and their carers. And although most of the patients had not used an assistive device. So the healthcare professionals mostly said that most of the ATs they were using more frequently were evidence-based, which were like FES, CIMT, and virtual realities, and robotics. But the only CIMT had evidence both by the UK guidelines and the EBRSR, and there was a mismatch between the strength of research evidence and the clinical use. I think that can be extrapolated into our setup also. We think that what we are doing is the best, but when we look at the literature, there may not be a high quality evidence for it. Another is on the display of AAC devices, where the visual scene display, the scene can be characterized and how it can be made more interesting by adding motion into the VSDs, categorizing them with photos relevant to the patient, and so on. An interesting aspect, probably we don't even look at AAC devices. Attila RCT, it was a large study with including 495 patients in the UK, aimed at establishing whether assistive technology can be useful. So a full package of assistive technology along with telecare, as opposed to a basic package where there was just a pendant alarm, a carbon monoxide detector, and a safe key, were assessed whether it improved the length of time that patients with dementia lived in the community, and they concluded that it was not useful, that a full package did not improve the length of stay in the community, which is huge from a perspective of public health expenditure. Another one on outcome measures. There are many instruments for measuring. So if we were to plan a study, there are definite AT outcome measures. Study on use after stroke, self-management of stroke. There was a 3-day exhibition of AT that was conducted, and then all the participants, 244 participants, interviewed, focus groups formed classified them, and then data taken from that research. Again, many people felt they wish they had known more, and lack of knowledge, not knowing what to do, this and lack of knowledge on the healthcare professional side were all cited as problems. CheckGate, why I've included this? It's on FES. So CheckGate is a pathway of FES prescription. It's a clinical pathway, which I thought was very interesting. And sorry, you may not be able to make out most of it, but essentially a 7 steps pathway where there is an initial assessment, all by a multidisciplinary team, led by 2 physicians, the referring physician or the PMR physician, physiotherapist, and an engineer, who would have periodic assessment. So after the initial evaluation and the basic assessment, the rehabilitation phase, and there is a loan phase where the person is given the FES device for home use. A 3-week period, comes back, reassessments, and only then the prescription is given, which is funded by the government, and interesting. So 80 articles are there everywhere, but how strong is the evidence? My question is, do we really need that strong an evidence? There is a high geographical, psychological, and disease or condition-specific variations when we practice. There are preferences for us as well as for our patients. And maybe what we should be looking at is creating evidence for our own individual practice settings, probably district or state level recommendations and guidance, and of course, a national guidance. Quick look, the priority assistive products list by the WHO has got 50 items. The national list of essential assistive products, we have 21 lists. Most of them we are very, very familiar with and discuss in our, prescribe in our daily practice. So to summarize, only a few studies showing a high quality evidence, no studies in the Indian context that I could find. Remember, keywords had to be assistive technology or assistive device. Methodological inferiority reported as the reason for the lack of evidence in most studies, although there are many randomized controlled trials which, by reading, I personally felt they were quite good, and I didn't really realize what flow was in it. Okay, and a lot of them talked about bias. Difficult to replicate these foreign studies and guidelines as structured programs and routine and early referral to rehab is almost non-existent in all our practices, although we do see a positive change in the trends. Indian studies are scant, heterogeneity of conditions managed, the rehab settings, the geographical and cultural variations. I personally feel with the 6 articles or so that I've shown here, that research in OT could be very simple, even the smallest rehab settings, if we go for more of qualitative studies. Yes, we may not have high quality evidence, but looking at the user feedback, the rejection rates, reasons for rejection, etc. Innovative qualitative researches may precede quantitative studies and then proceed to high. So we may need that transition slowly on to quantitative studies. Increasing awareness is definitely the key. NLA EAP promises a shift towards evidence-based practices. I'll take 1 more minute, sir. Direct referral. Another problem that I want this audience to note is the direct referral to manufacturers and off-the-shelf purchase is detrimental to our practice and research in particular. Charity devices, they probably worsen the scenario. We must provide a complete prescription wherever possible, and a good classification and a coding system may be provided. It may provide better acceptance, and a sample program is the AMLA Assistive Devices Support Program, where we support patients financially if the prescription has been given by us, key being appropriate AT device. Okay, thank you. I'll stop here.
Thank you, Dr. Sindhu Vijay Kumar. Are there any questions, please?
Listen. Yes. Yes. I would say yes as my first answer. Again, this is from personal experiences and from not from research. Personally, I really feel many a times, especially transfer devices, even wheelchairs, positioning systems, all that people say no, because it may be more, not just easier, but cost efficient to hire a person who would also do other things, right? Like if a device for transfer will only do transfers, but a person hired would do the cleaning, the feeding, and the transfers. So yes, that is a major factor. But then if we can, or if I can, put it into a study, I think it might make more, a better answer probably.
Okay, thank you, Dr. Sindhu.
Thank you, sir.
And next speaker is Dr. K.M. Matthew. He has been one of my mentors at St. Stephen's, Delhi, and I have learned a lot from him. A glimpse of that would be included in my tomorrow's presentation, and today we will learn from him about immunocompromise in spinal cord injury.
Hi, thank you. Basically, I'm interested in clinical interventions and so on. So if I come across a clinical problem, then I'd like to investigate it a little more. The reason why I'm saying that is I'm not like a regular professor who formulates a question and then tries to hunt for an answer. It's just that in my clinical practice, so how do I manipulate this? It's not moving though. Oh. Yeah, but it's just, okay, thank you. So, greetings from Astor, that's where I come from. That's a real picture, it's not a made-up one. If you look at figures in the UK, that is 2013-14 clinical reference group data, you find that most of the spinal cord injured now are cervically injured. We had a set of figures in 2021 in Astor. We had 58 spinal cord injured. 29 of them were actually cervically injured. So we are not very different from the West in that sense now. So we come across similar problems too. I just want to talk to you about 3 or 4 patients. That was a 21-year-old who had a C6-7 fracture dislocation, rather severe. So you can see the lesion going all the way up to C2. He also had polytrauma, and one of those problems was contused lung. He was in the ICU for 45 days trying to get rid of a chest infection that he had. And he had urosepsis on 2 occasions, blood culture positive 1 occasion, and he had multiple urinary tract infections after he left us. This is a 32-year-old patient whom we discharged fairly recently, and you can see he had a lower respiratory tract infection 10 times, with a UTI twice, and so on. Multiple infections occurring all the time. We were just trying to firefight these infections most of the time when he was with us. It's a 70-year-old gentleman who came to us similarly. He was discharged with a tracheostomy tube, and he was getting multiple infections also. Just wanted to show you that picture where you can actually see the faint shadow of a collapsed lung, which is consolidated too. And eventually, after going home, within 6 months, he died of a chest infection. A 58-year-old man had similar problems, and you can see basal consolidation here and multiple infections in the chest. This is a 53-year-old patient who had ankylosing spondylitis, again, multiple bronchopneumonias, and so on. So I wanted to look at what constitutes this, and we know, we have read that these are caused mostly by immune compromise. So I just read up a little bit more, and I thought I'll share what I read. And we have studies, many studies that show that pneumonia is the leading cause of death in all post-injury periods. There was a retrospective follow-up study of spanning over 70 years in the UK, and they found that 40% of deaths in all spinal cord injured patients was respiratory related. So now we have a fairly, looking at the literature, it looks as if we have a fairly settled view of what is happening. And the first thing among them is the fact that you have low-grade chronic inflammation going on in spinal cord injury. How do we know that? If you look at all these parameters, you see that they are all elevated, and which was indicative of chronic inflammation. The other thing that is going on is immunosuppression. We'll delve a little bit more into that. And we now know that sympathetic preganglionic neurons are situated in the intermediate horn of the gray matter. They seem to be activated much more than normal. We now know that there are interneurons that are glutaminergic. They are excitatory in nature, but GABA neurons that come from above usually keep it inhibited. In the absence of that inhibition, we have activation of the interneurons that are glutaminergic. They tend to activate the spinal presynaptic neurons, and eventually, when the circuit goes on for more and more times, the number of dendritic synapses that you get on this from these interneurons seem to increase. So we have now evidence that there is definite plasticity in the spinal cord with interneurons that are glutaminergic. What that does is to then stimulate the spleen, and the stimulated spleen puts out a large amount of norepinephrine. It also produces atrophy of the spleen, and we know definitely that the spleen size is reduced. Similarly, the number of cells, CD4, CD8, natural killer cells, all these tend to come down. So it was Brommer et al. Who did some more work on this. We know clinically that when you have a high spinal cord injury, you tend to be more immunocompromised. So Brommer et al. Was trying to find out why, and if it could be avoided or prevented. So we know that when you have a T3 level injury, a significant immunodepression, not so when you have a thoracic 9 injury. And in T3 injuries, you see there is significant reduction in the size of the spleen. It is significant. It has reached significance. So what he did was to try and see whether we can replicate this. So he took rats and he cut the spinal cord from the back, and that included the intermediolateral column and the funiculus lateralis, which actually synapse with the spinal presynaptic neurons in the intermediate horn. These tracts actually bring in inhibitory signals from above. So this was the experiment he did. He first cut the thoracic 9. We already know that T3 produces more immunosuppression than T9. So he produced this at T9 and then saw what happened to the spleen. The spleen was reduced in size. Then what he did was to actually cut the postsynaptic nerves that innervated the spleen, and he found that the spleen size actually did not change. The postulate, when you did that at a transaction at T3, was that the spleen sizes actually reduced significantly. But then what he did was to do the same thing again. Postsynaptic nerves were cut, and then found that the spleen sizes did not change appreciably. So this was the postulate finally that he had, these 4 columns. If you have high thoracic spinal cord injury, there will be functional spinal cord induced immune deficiency syndrome. If you have low thoracic ones, it did not cause it. And preganglionic injury caused functional SCI IDS. Postganglionic injury does not cause functional SCI IDS. So essentially, now we know that if you protect the spleen from the inputs of these spinal parasympathetic presynaptic nerve inputs, then you will not get any problem with the spleen, and the cells do not reduce in number. So we'll look at it again. The cortisol levels in acute spinal cord injury rises dramatically. 1 day post-injury reduces a little bit, and you can see the diurnal variation where it is really peaking a lot at 3 days post-injury. You can also look at the serum cortisol level and the splenic norepinephrine levels. If you did a sham, just a laminectomy, no problems. Contusion, some elevation at T9. T9 transection, a little bit more. But if you did a T3 laminectomy, similar here, T3 transection, it's way up there. And the same thing with the norepinephrine. And mind you, the more norepinephrine you have in the spleen, the less number of cells you get. So if you look at this again, the spleen weight is significantly reduced. The splenocyte count is actually significantly reduced. And then you look at the apoptosis of splenocytes, this is actually significantly raised. It's done through caspase 3. You can see that it's very large there. And you look at cell numbers, specifically B cells that are very severely depressed, T cells not so much, dendritic cells not so much. And the apoptosis of B cells is severe, and that can be actually seen by doing this annexin V. So in short, after a cord injury, your natural killer cells decreased, your T cell function decreased along with T cell activation, your B cells decreased and B cell apoptosis increased, and ACTH increased along with urinary cortisol levels. So the same team, Professor Schwab's team, to which Brommer belonged, they did another test, because all these tests that were done were preclinical. And Professor Schwab's team were trying to do and see some experiments to see whether we could actually predict or look at immunocompromise by doing some blood tests. And they came upon this one, which is the monocytic HLA-DR test. What they did was to count the number of antibodies that stuck onto this, which was a measure of the level of immunity one had. If you had 15,000 of those, then you had good immunity. If you had 5,000 or less, you were immune paralyzed. If you're between 5,000 and 10,000, you had immunocompromise. And what was evident was the HLA-DR antibody counts was highest or lowest in Asia A T1 to T4 group. So remember, we want to recap this. Natural killer cells decreased, T cell functions decreased along with T cell activation, B cells decreased, apoptosis increased, and cortisol levels were high. The good news is this. With active rehabilitation, we have proof that NK cells increase. But unfortunately, they seem to actually drop off once you stop the therapy input. But T cell functions increased, and T cell activation also increased. Unsurprisingly, FIM scores were also up. But that is good news, isn't it? Similarly, there was more experiments, or not experiments, they were trying to see how we can inhibit the activation of the spinal presynaptic neurons. Is there any, okay. To cut it short, there are things you can do. TNF alpha, gabapentin can actually reduce the plasticity, and you can also change the chronic inflammation by changing the gut biome. That's the last one. The future is probably immune modulation with probiotic and gene blocking. And autonomic hyperreflexia could be prevented possibly with large doses of gabapentin or TNF-alpha. Thank you.
Thank you, Dr. K. Matthew. That was an excellent presentation. Open for questions, if any. Well,
Thank
if
you.
there
There
are
is
no questions here.
no questions. Thank
Yeah.
you.
Okay.
The standard population to see whether it makes.
Henry, I just told that I actually look at clinical problems that I face and then try to see what I can learn from it. No, the answer is I have not specifically looked into it, so I do not know. But possibly, if you already have immune compromise, then you're likely to suffer worse. Okay.
But then the point that the NK cells and T cells, B cells with physical activity improve is quite well proven. And
yes,
I
yes.
think that's the way to go forward.
I think so, yeah.
Is there any way of stimulating the spleen, in studies or anywhere, to avoid this?
The problem is splenic stimulation with norepinephrine. That is what reduces the spleen size. It reduces
No.
B cells and so on.
Suppress parasympathetic activation or do something else.
Well, that is already there. Vagus is not affected. So we know that that is not the problem. We know the problem is cutting off of sympathetic modulation.
No, but so if we were to stimulate the vagus, do you think we'll be able to counteract the effect? That is what I'm coming.
I don't know. That has not been looked into because they know that the vagus is not affected in cord injuries. So,
Thank you. Thank you.
okay, thank you.
Next speaker is my friend from West Bengal, Dr. Kshetra Madhav Das, and he is a consultant in Fortis WEMES, and he would be speaking on rehabilitation of acute soft tissue injuries of ankle encountered in sports. Dr. Das, please.
Namaskar, Vanakkam. Good morning to everybody. Respected chairpersons, my senior, contemporary, and junior colleagues. Today, the topic of my talk is rehabilitation of acute soft tissue injuries of ankle encountered in sports. Basically, I will deal with some basic things after all these sophisticated things. And I believe that the 360-degree rehabilitation doesn't exclude the basic things. And I have specifically chosen this background because at the right bottom corner, there is a 360-degree circle which exactly matches with the theme of our conference, PMR 360-degree. At the outset, I would like to thank the organizing committee for inviting me and giving me this opportunity, rather. To start with, the basic things, components and tools of rehabilitation. All of us know that there are 5 components: the control of acute inflammatory process, the regaining full ankle range of motion, increasing muscle strength and power, improvement of proprioceptive abilities, return to daily activities, and that definitely includes the sports activities. And those 5 components come as a phased manner, 1, 2, 3, 4, 5, and they incorporate both generalized as well as individualized approach. And different component, different tools are being used. Some are used in the acute and subacute phases. I'm not going into the details. And some, like the task-specific functional rehab and the structured progression of exercise, falls under the subacute and chronic phases. And these two, that individualized approach and the task-specific functional rehab, are the 2 most important keys to open the lock of success as far as ankle rehab in the acute sports injury of ankle is concerned. Now, the phases of rehabilitation somehow goes hand in hand with the phases of wound healing. As we know, the days 1 to 5 is the inflammatory phase, there our main target is to protect the injured tissue so that the secondary inflammatory response doesn't get inside it. And from the next stage, that means the post-acute phase, the 6 to 42 days, we usually start supervised and protected stress on the joint to promote the wound healing with the aim of full functional activity. And that is again divided into two parts. The days 6 to 21 is, as you know, the proliferative phase, and the days 22 to 42 are the maturation phase. They are the initial of this ROM and strengthening exercise is given, and then the proprioception and task-specific training is introduced gradually in the maturation phase. And now some practical point to ponder. Rest, whether it is absolute or relative. The answer is simple, it is always relative, because the tensile strength of the muscle and tendons starts getting diminished as early as 24 to 48 hours. And that is the reason we should not wait up to the day 6 for instituting ROM exercise. And we should start it, but it should be within pain-free ROM and shouldn't create the re-injury. So we shouldn't overload the joint, and it definitely depends on a case-to-case. Now coming to the phase 1, that is, we know that depends on the price and other things, other NSAID and all those things. Price means protection, rest, ice, compression, elevation. A few patients needs non-weight bearing, though most of them requires only partial weight bearing. Likewise, a few patients do need immobilization, but others, mostly stabilization. Stabilization is all the thing which is required. And the rest is always relative. And now coming to the ice, but this rest has been questioned by a new principle, that is the police principle, recently introduced, that tells about the protection, optimal loading, ice, compression, and elevation. They are questioning the necessity of rest, and they are actually arguing that rest is going to reduce the chance of proper healing of the tissue. So they are advocating about the optimal loading from the very beginning. And ice is given in almost all the cases we have seen in the sports injury arena. But again, this ice or cryotherapy has been questioned by a very recently introduced Peace and Love. Peace and Love stands for protect, elevate, avoid, compress, educate, load, optimism, vascularization, and exercise. I'm coming into that to the later, and then compression and elevation, as we know, it are very helpful. And in the pharmacotherapy, we can use NSAIDs, but as I was talking about the Peace and Love principle, there's an avoid. The third point is avoid. And they are telling about avoidance of NSAIDs and also avoidance of cryotherapy, because it is being believed and the evidences are coming that use of NSAIDs and the use of cryotherapy, including ice, is actually hampering the proper healing process, the natural healing process. And that is the reason whatever the evidence is saying, we should use these two only judiciously in a very conservative manner, owing both the pros and consequences. Now coming to the second phase, the phase 2, range of motion, and the full range of motion is the prerequisite for full functional rehab. So this is a very important step. And as I have already told, that not only the tensile strength gets reduced, but the Achilles tendon gets shortened even within the 48 to 72 hours. So often the range of motion exercises coupled with Achilles stretching exercises, and that can be done by the passive range of motion exercise or by the active range of motion exercises, which can be again single plane or multiple plane. And that single plane exercise may be in the non-weight bearing manner. It can be done in the weight bearing manner like this, and also with the help of the resistance, we all know. And that multiple plane, the so-called alphabet exercise, is very important as far as ankle rehabilitation is concerned, because it has a specific advantage of increasing the proprioceptive inputs, and that is the reason why it is often called the non-weight bearing proprioceptive input enhancement exercises. coming to the phase 3, it is all about strengthening. Both the isometric and isotonic exercises are instituted, though there are only a little evidence behind the kinetic exercises, but some institute use that, and some evidences are also there. I'm not going into details of that, but the clinician or therapist-assisted manual resistance is almost always preferred as far as the evidence are concerned. But when this is not available, this is not practical, only then the daily adjustable progressive resistant exercise or DEPRI can be instituted. Coming to the next phase. Oh, before going to the next phase, again, some practical point to ponder. These are very important, very basic, but very important. We shouldn't forget these things. The isometrics, to start with, it should always be submaximal, and to start with, it should be 50% of the full volitional activity, and then it should gradually increase. Otherwise, reloading or undue injury may happen, which will re-injure the already injured tissue. And wherever possible, the multiple angle exercise should be recommended, because it has been shown by the studies that the actual increase of strength occurs 10 degrees of either side of the particular angle against which the isometric exercise is being done. So recommendation is exercise at every 20 degrees throughout the full available range of motion. And regarding the isotonic exercises, we should introduce OKC and CKC both, though CKC is the definite isotonic exercise of choice at the initial period after the tendon and ligament injury, but as soon as possible, the OKC should be substituted, and those should concentrate not only on the concentric contraction, but also on the eccentric contraction, because eccentric contraction has tremendous effect, tremendous ability to control the different activities, especially the anti-gravity activities. And the ankle joint has plethora of anti-gravity activities. Think about jumping from height, running, jogging, dancing, walking. Okay, forget about all these high-impact activity. I'm talking about just a low-impact, very basic, the gentle pace walking. To make a single step, 1 foot forward at the time of heel strike, it has been calculated biomechanically, that the energy produced inside the ankle or inside the knee are sufficient to shatter all the ligaments of ankles and knees, the most important static stabilizers of the joints. But this doesn't happen. This doesn't happen because of the quote-unquote negative work done by the eccentric contraction of the antagonistic muscles. So the coupling of positive and negative work done by the concentric contraction of the agonist and the eccentric contraction of the antagonistic muscles, respectively, is the all-important thing for the joint stability. So the recommendation is isotonics should be done at very slower pace so that the eccentric contractions of the muscles are properly achieved. Now coming to the phase 4, that is the proprioceptive and balance training. That can be started with non-weight bearing at the very beginning, at a very early period. And even the oval board can be used in the non-weight bearing manner like this. Then the oval board or BAP system can be used. That can be uniaxial, multi-axial, non-weight bearing, bilateral, unilateral, with open eyes, with closed eyes. Basically, with progressive challenges and progressive difficulties, we can use these. And the different surface walking can be instituted, manual PNF exercises with variable perturbation, and the random functional movement can also be introduced in the later phase. Now coming to the phase 5, the return to sports specific training. This is very important because our goal is to make that athlete able at least to the pre-injury level, or if possible, to the better level. And so this is the final phase. This is time-consuming, but we should be very patient with our patients. And this is done in a phasic manner. At the very beginning, the functional exercise on different surfaces with variable resistances. And if there is no pain, no discomfort, then we progress to the second stage that constitutes of 50% walk and 50% jogging. And if there is no pain, we progress to the third stage, that is the 50% jogging and 50% running. That is the just before when the athlete is introduced to the actual sporting arena. And these two phases, again, done in a very sequential manner. Initial, the straight movement, straight line movement, forward movement, then sidewise, then backward, and only then the pattern movement, the curvilinear movement. And that too starts with circular motion, and then figure of 8 or other complicated or more complex figures, curvilinear figures. And the specific functional exercise is important to stress the healing tissue, because we know these depend on the SAID principle, the specific adaptation to imposed demand principle. And when I opened my third vision, in search of 360-degree, I found many other things in ankle rehabilitation. Those are a little bit of outside the basic arenas. And unfortunately, there is no conclusive, yeah, I'll finish now. Unfortunately, there is no conclusive evidence that minimally invasive procedures can be effective in the, at least in the acute injury, though they can be tried in the chronic cases, the failed cases. Orthosis has different, various positive effects. They can be used in the acute phase and as the prophylactic stabilizer or prophylactic support in the later phases. And when there is some biomechanical issues like foot malalignment, etc., they can be used for the all activities in all stages. And robotics also has different various advantages, but these two disadvantages are practically very important in real life scenario, at least for now. And these are the goals of ankle rehab, the 3 T's: treat the tissue, trigger the function, and terminate the cycle. Not only the pain spasm cycle, but also they terminate this CAI, chronic ankle instability, ankle injury, chronic ankle instability, this vicious cycle, because the chronic ankle instability is predisposed by neural, muscular, and mechanical malfunction, and the proper ankle rehab targets these 3 components to terminate this vicious cycle. And the chronic ankle instability, muscle weakness, inverter-reverter asymmetry, bipedal asymmetry, postural instability, all predisposes to ankle injury, and the ankle injury again predisposes to those things. So proper ankle rehab also terminates this vicious cycle. What can be asked more than this? A treatment, a management which treat the tissue, regains the function, and also prevent the future occurrence of ankle injury. So it's a wholesome thing, I guess. Thank you. Dhanyabad. Nandri.
Excellent, excellent talk. Any questions,
so
please?
Thank you, Doctor.
Welcome.
Excellent talk. My question is, you have explained about the duration for certain stages of healing and progressing with certain exercises based on that. So I would like to ask that I usually follow a criteria-based progression in ankle rehab rather than a duration-based progression, because the severity of injuries varies and the recovery process also varies in time between individuals. What's your thought on this?
Yeah, what you have told is absolutely right. And I thank you for the very pertinent question. There are 2 parts. I have mentioned both. Okay, I told often it goes hand in hand. So that was a time-based framework. But at the same time, I told that individualized approach and the case-to-case base, which depends on the case-to-case, and the task-specific activity are the 2 important keys to unlock the success. So as you formulate your program, there is no hard and fast thing, neither in time-based or the criteria-based. Okay, it depends on what you follow is absolutely right. This is just for the framework. What may be the duration, what may be because I have to tell something about the generalized thing also. Okay, the individualized approach is very good, and you can take anything. Rather, it is better to take the criteria-based as far as individualized approach is concerned.
You prefer the CKC exercise to begin with before the OKC exercise. I would like to know the reason, because what I would personally do is to start with the range of motion initially in an open kinetic chain position and then progress to closed kinetic chain, because there are various forces that act on the ankle when they do it in a closed kinetic chain position. So what's your thought on that?
Thank you for a very interesting question. Actually, I didn't say I feel or I opine, because I don't feel that I'm in a position to opine on something. What I am saying is absolutely evidence-based. I'm a learner. I learn from the evidences, because lots of studies are doing. I may have done a 10 or 20 or 30 studies, but the evidence are based on the millions of studies. So there, in any kind of joint stability, be in the knee, be in the ankle, the CKC is the starting exercises. And when we talk about CKC and OKC, we are actually talking about isotonic exercises. ROM exercise, in range of motion exercise, it doesn't depend, it is not divided into CKC or OKC. In the range of motion exercise, you can start, I told, it can be started at the gravity eliminated position. So no question of CKC or OKC is there. That is purely range of motion exercise. When we talk about strengthening exercise, that is divided into isometric, isotonic, and isokinetic. And the isotonic exercises, again, is divided into two types. Number one, the CKC, and number one is OKC. It is evidence-based thing that in all sorts of ligamentous and tendinous injury, you can recall that ACL injury, there is also the CKC is the initial exercise of choice. Dr. Joy Singh has another question, I guess.
I'm afraid.
Yeah. Okay, but I also practice that when isotonic exercise, as far as isotonic exercise is concerned, in my practice, I follow the evidence and I start with CKC. Okay.
Okay, thank you, Dr. Das.
Welcome.
We had an excellent workshop. Thank you. We had an excellent workshop on critical care rehab under my fellow chair, Dr. A.J. Rajendran. Part of that was on a video on ECMO that is
The mobilization, make them upright, make them walk, 100% it is possible. That's exactly what we would like to show here. our patients upright and walking. And sometimes our patients are there with us for 30 days, 60 days, 90 days, and some, more than that also. So we cannot afford to lose the thing. The most important thing is ICU-acquired muscle weakness, which we need to counter and effectively make them mobilize. I end with a quote from Hiroshi Nakashima. Hiroshi Nakashima was the Director General in 1996 of WHO. He says, increased longevity without quality of life is an empty prize. So this is exactly what we are trying to do. We are trying to restore the quality of life. Thank you.
Thank you, Dr. Rajendran. May I also request you to share the video links at the critical care workshop group. Any query, comment? Okay, thank you. My second guru in this session, Professor Sanjay Wadhwa, is currently professor and head of Department of PMR at AIIMS. And he would be sharing his talk on short and sweet history of PMR. And I am sure, as always, his talks have been quite crisp and short. And it will also add to the history of PMR chapter that in the book that we released yesterday. So, Professor Wadhwa, sir.
Thank you, Dr. Gogia. I think you are my guru rather than the other way around. I learn so many things from you. But thank you anyways. Good morning, all of you. I will be brief because I think we are running behind schedule to some extent. So the history of IAPMR is more than 50 years old or young. I don't know what term to use because we are still young and growing. And in the history of an association, 50 years is not a very long time period. But traditionally, the Golden Jubilee, the Silver Jubilee, the present times, and the future, these are important concepts by which we can discuss the history of an institution, association, or a monument, etc. So I will briefly organize my talk around these points. IAPMR is an association. We all know, we are all part of that. It has a genesis. It was formed in the year 1972 in the Lecture Theatre 1 on the first floor at All India Institute of Medical Sciences, New Delhi, when a few enlightened men and a woman met and they thought that there is a need for this organization or association in India. And one of the reasons why they thought this way, they were all trained abroad. They had been exposed to these things and they were men and women with vision and they were willing to create something new because of the love and affection and passion for the specialty. Very soon they gathered, they drafted a document which is the memorandum or the rules and regulations. They gave it a name, Indian Association of Physical Medicine and Rehabilitation, and they submitted it for registration under the Office of the Registrar of Societies in India. And the registration was granted, a logo was developed and designed, and this is how we have been growing slow and steady steps. The membership has grown. Of course, one can always compare with other associations and feel unhappy that our growth has not been as rapid as some other associations, but still we have been growing. The rate of growth can be always debated, and partly for the slower rate of growth, we ourselves are responsible. Who is stopping us from increasing the membership and opening more and more state chapters? But despite my saying this at every platform, we are not opening more and more state chapters. And the sphere of activities has definitely expanded, and we have always risen to the challenges. And one of the biggest challenge in the recent times was the COVID-19 pandemic. And I'm very proud to say that Indian Association of Physical Medicine and Rehabilitation also responded in a very positive way to this challenge. And they continued the activities, although in a very different scenario, making use of the technology at that time, which was considered relevant and effective. And we could reach and we can send the messages across to the people. And we did not stop our activities. This was a very big challenge, and IAPMR deserves full credit for that. And by IAPMR, I mean its members and office bearers. I always like to share this photograph of the first executive body of Indian Association of Physical Medicine and Rehabilitation. This is what I printed in the first directory of our association. Dr. Mary Varghese was unanimously chosen as the first president of our association. Dr. B.P. Yadav, Dr. A.K. Mukherjee sir, Dr. P.B.M. Menon, Dr. S.K. Verma sir, and Dr. Mrs. V.V. Gujral. These were the other members. We have highest of the regards for Dr. Miss Mary Varghese. She was the first president of IAPMR, and she was herself a wheelchair user as a result of a spinal cord injury in a road traffic accident. And she is considered, without any doubt, one of the most respected pioneers of PMR in the country. She had the opportunity of being trained under Dr. Howard Rusk and some of the advanced centers, and she put into practice the skills and the knowledge and information that she acquired at those centers of learning, which are still considered the Makkah of PMR. And she was well connected, absolutely committed, and she touched millions of hearts, and she was conferred the Padma Shri by the then President of India, Shri V.V. Giri. And we all praise her for what she did for our specialty. But I have a different take also, without taking any credit away from Madam Mary Varghese, that the President alone cannot do everything. A President requires a very efficient and able and hard-working secretary. And I am very proud to say that a part of the success that our association deserves or gives goes to Dr. B.P. Yadav sir. And I was fortunate to begin my PMR career under the guidance of Dr. B.P. Yadav sir and then Dr. R.K. Srivastav. And I would like to name these two people for having done a lot for the growth and development of our association and the specialty. The other person whom I would like to name is Dr. W.G. Ramarao. He was another very dynamic person who used to travel a lot, and he had good friends in various other professional associations also, including Indian Orthopedic Association, Indian Association of Rheumatology, and you will be surprised to know that he was president of both these associations also, besides being president of IAPMR. And he was also president of Indian Association of Sex Educators, Counselors and Therapists. So a multifaceted person, very dynamic, very hardworking, traveling, and most of the time spending money out of his own pocket and savings. And other than conducting annual conferences and occasional CME programs, IAPMR was participating in various other academic programs also. And this is the proceedings and recommendations of one of the national level seminars on cardiac rehabilitation, which was held in association with Indian Association of Physical Medicine and Rehabilitation. The first directory of IAPMR was brought out by me in the year 1990 to precede the organization of an international conference at Delhi in 1991. And the genesis of this was when I saw the World Directory of Physical Medicine and Rehabilitation, which was brought out by Sidney Licht. And I was encouraged by Dr. W.G. Ramarao that you should work on this and you should develop and bring out a directory. And I was encouraged also by Dr. K.K. Singh, who was the head of the department at that time at AIIMS New Delhi. And this was followed by other and much improved directories of Indian Association of PMR. In the year 2000, it was brought out by Dr. Rajendra Sharma sir, and in the year 2006 by Dr. B. Ramachandran sir. They were with photographs of members and more rich in content. And now we have moved on to the electronic formats, and our membership and details about various other things are on our official website. Besides these directories and annual conferences and proceedings, the association also brings out official journal of Indian Association of PMR. The first editor of IJPMR was Dr. Ashok Agarwal from Lucknow, and he was very hardworking. He brought out several issues of the journal, and the flame or the torch was handed over to another very capable person, Dr. U Singh sir, who carried on the editorship of the journal for many years. and he gave it a different identity and shape and brought out regularly for many years. The next editor of the journal was Dr. Atin Haldar from Kolkata, followed by Dr. Rajesh Pramanik, and now Dr. Mrinal Joshi. Newsletter or bulletin of IAPMR was also brought because it was felt by the association that there are a few things which can be better conveyed through the newsletter, which is smaller in size and perhaps with increased frequency. And the first newsletter was called the Rehab Talk, and this was brought out by Dr. S. Sundar, and he deserves a lot of credit. Taking a cue from the content and the trends internationally, I was given the responsibility and I named it to the Bulletin of IAPMR based upon the WHO Bulletin and Bulletin of Surgery. But due to various constraints and reasons, I could bring out only one issue, and then others have continued successfully, and currently also it is coming out regularly. Souvenirs every year, every conference annually brings out a souvenir which is very rich in content with many other facets and aspects related to the activities of the association. And proceedings I have already shared with you on one topic, that was cardiac rehabilitation, but there are several other topics also on which the proceedings have been brought out. The first conference was a landmark event in the history of IAPMR, and it was held at Delhi, and Shri V.V. Giri, the then President of India, was the chief guest. The Silver Jubilee Conference was held at Jaipur, and the Golden Jubilee Conference again at Delhi in the year 2022. And this is a photograph as a representation of the Golden Jubilee Conference at IAPMR. We had a logo of our association, but to commemorate this Golden Jubilee Conference, it was decided that we should come out with another logo specific to the Golden Jubilee Conference for that particular year. And that is also depicted in the middle of the two logos of the IAPMR. And the chief guest was Dr. Sahasra Buddhe, member of Rajya Sabha. And here in this photo you can see to the right of chief guest is Dr. A.K. Mukherjee sir. He is one of the two surviving founder members of our association, the other being Dr. P.B.M. Menon sir. And this is another leaf in the history of IAPMR. Yesterday, the IAPMR textbook was released, and I am very proud to share that photograph, which I got through the WhatsApp group, and I congratulate Dr. A.K. Joy Singh and all others who have been associated with this. And it will, I think, encourage many more activities, because the book will last for much longer than a session in the conference or a lecture. But it is not that everything is going on beautifully well and we are growing by leaps and bounds. Still, there are several hiccups, challenges, roadblocks. So it depends on you whether you are a person who looks at the glass as half full or a person who looks at the glass half empty. My feeling is that we should be realistic rather than blindly optimistic or blindly pessimistic. Competition and comparison with other association in order to encourage us to do well and better should always be there. Instead of having an ostrich-like approach, nahi, hum sab theek kar rahe hain, we are doing great, we are the best, we are wonderful, we are on top of the world. So being aware of the challenges and preparing how to face those challenges is also very important, and we should not hesitate to do every 5 years the SWOT analysis as related to our association. What are our strengths? What are our weaknesses? What are the opportunities that we have in front of us, and what are the threats? It is a scientific way of moving forward so that there are no sudden surprises or setbacks. So this is what I wanted to very briefly share with you, and I am very thankful to Dr. Chellaswamy for giving me the time, and I am thankful to all of you for listening to me. Thank you.
Thank you, Professor Vadva sir. It has always been a pleasure listening to your talk, crisp and precise. I don't think there would be any comments, but of course compliments are invited.
But I can pose a challenge to the younger generation. What I have shared has been done by people who were senior to you. So you should not become complacent and just rest at the hard work done by them. Now it is your responsibility to carry the torch forward and ensure that it keeps on burning bright. That is my humble request and challenge to all of you. Thank you.
Sir, please stay on, and may I request all the speakers to come on stage for felicitation.
Chairpersons. Dr. Chairperson.
See, I could not say one sentence that one of the chairpersons, Dr. A.J. Rajendran, is one of the pioneers who specialized further and took off cardiac rehabilitation as an area of his interest. We are, most of us, confined to the locomotor rehabilitation, but he is one of the first persons in IAPMR who took off and further developed cardiac rehabilitation. And Abhishek took on neuro rehabilitation in a very big way. Thank you.
Sir, request the chairpersons to facilitate Dr. Partha Pratim Rai. Dr. Madhushri Sengupta. No. Dr. Partha Pratim Pan. Dr. Madhushri Sengupta. Dr. Sindhu Vijay Kumar. Dr. Sindhu Vijay Kumar. Dr. K. M. Matthew. Dr. Kshetra Madhavdas. And I call upon Professor Dr. Tinavakar sir to facilitate the chairpersons. Dr. Sanjay Wal. Dr. Abhishek Srivastava. Dr. Abhishek Srivastava.
Actually, I was. Being a chairperson, I was abusing my position a little bit. Dr. Abhishek, please stay on. Actually, we had a CME on stroke rehabilitation in Lucknow, and Dr. Abhishek was online star speaker. His memento presentation was left.
Morning all. Welcome to the scientific session 9. So I welcome the chairpersons, Professor Dr. Tirunavakara sir, Professor Akojim Joy Singh. Welcome sir. So scientific session 9 starts from right now.
Very good morning to all here, and we are going to the scientific session 9 of this conference. I welcome all of the delegates for this wonderful session, and there are about six speakers. And since we are running short of time, I have the pleasure of inviting Dr. Ashanand Papalwar, the Assistant Professor of AIIMS Nagpur. I will be talking on telemedicine-based pulmonary ablation. Welcome, Dr. Ashanand.
Thank you, respected chairpersons, my seniors and colleagues. After the exhaustive high-tech video of ECMO, starting with this telemedicine-based pulmonary rehabilitation. In pulmonary rehabilitation, telemedicine use is quite new, and a lot of new areas are there to explore more. So as you can see into the image, what's the difference between the lung capacities of these two people? One is I would say, climber, and another is a sedentary person with a sedentary lifestyle. So the question is that capability of high work performance can be attained by proper conditioning of body by regular exercises. So the question is that, can you utilize these performance enhancing skills for the various chronic lung diseases? And the answer is yes. And this is the core of the overall pulmonary rehabilitation theme. So I shall be talking on the prevalence and pulmonary disease, then benefits of pulmonary rehab, then assessment for the telemedicine-based pulmonary rehab, then execution and setting up of a pulmonary rehabilitation clinic, especially telemedicine-based for the youngsters. So the idea of the presentation is that few of you may get the confidence after this presentation, and I believe that some of you can definitely start the telemedicine-based pulmonary rehabilitation setup. So WHO published the document, and it says that nearly 65 million people have various types of COPD with the 5% of death. If you see the Indian scenario, the situation of India is worse. It is significantly affecting health-related quality of life. And the recent meta-analysis says that 7.4% is the prevalence of the COPD in India. So to quickly, briefly summarize the pulmonary diseases, there's basically common two categories, obstructive pulmonary disease and restrictive pulmonary disease. In obstructive, we have basic simple four categories like emphysema and chronic bronchitis, asthma, bronchiectasis, and cystic fibrosis. And for the restrictive lung diseases, again, the interstitial lung disease of idiopathic pulmonary fibrosis, sarcoidosis, scoliosis, and other neuromuscular conditions. So to find out this proper level of evidence for the pulmonary rehab, the 1A recommendation is it definitely reduces the dyspnea, improves health-related quality of life. 1B recommendation is beneficial for some patients with chronic respiratory disease other than COPD. Then a 2B recommendation, it reduces the hospital stay or number of days spent in the hospital. And then it provides psychosocial benefits, again 2B recommendation. Then it is definitely cost effective, 2C recommendation. And the important is that there is insufficient evidence to determine whether the pulmonary rehabilitation improves survival of the patient. But definitely, yes, it improves the quality of life. So broadly, pulmonary rehabilitation, it's basically divided into two categories: institutional-based pulmonary rehabilitation, where the patient visits the PR center, he does the exercise session, therapy sessions, and goes to home. And another newer coming up is a telemedicine-based pulmonary rehabilitation. So this was study published in 2021. This is a study from the Iran. They explored this, what are the different barriers for the institution-based pulmonary rehabilitation center for the patients of COPD. And the findings were that there are barriers were divided into basically three categories related to the patients and their families, inefficiency of pulmonary rehabilitation services, and inappropriate organization in the context of pulmonary rehabilitation. They digged up a little bit more that what are the difficulties, why patient regularly doesn't come to the pulmonary rehabilitation center at the institute. There are many times there is a lack of knowledge to the patient as well as families. There is a heavy financial burden, lack of patient-centeredness, coordination with the PR team, inadequate professional competencies, limited access to the pulmonary rehabilitation services, ineffective PR planning, discontinuity of care. Yes, and definitely transportation and other issues. Because a healthcare giver has to be accompanied to the patients of COPD with moderate to severe affected patient. So I believe that all these above barriers can be very well tackled by the meticulously designed, well-defined telemedicine-based pulmonary rehabilitation program. And it is very much essential, and the pulmonary rehabilitation program can be beneficial and survival in terms of the benefit to the patient. So the telemedicine-based pulmonary rehabilitation program, in 2020, in the middle of the COVID, Government of India has taken a very landmark decision and published this Telemedicine Practice Guidelines 2020 for all types of specialties with the various set of guidelines. What are the things, modes of communication we are supposed to use, like text message, video call, audio call, etc. What are the various types of consent we are supposed to take from the patient, the various digital technologies, as well as what are the drugs which can prescribe. There is nothing specific for the rehabilitation point of view in this guideline. So they defined telemedicine as it's a delivery of healthcare services where the distance is a critical factor by all health professionals using information and communication technologies for the exchange of valid information for diagnosis, treatment, and prevention of disease and injuries, and etc. So the telemedicine brings the healthcare service at the doorstep to the patient, to the common people, and it has removed multiple barriers like accessibility, transportation, time, money, and inconvenience. So the question is now, what is the evidence of telemedicine-based pulmonary rehabilitation for COPD and other diseases? So this P. Day, Roos et al., they studied this home-based walking program on physical activity, and then another study for in-home pulmonary tele-rehabilitation program. And all these two studies, they express that there is a domiciliary exercise-based tele-rehabilitation program under supervision of via electronic media is very much effective for the patients of COPD. Then in the COVID, there is one study, there's a review article regarding this proposal for multidisciplinary tele-rehabilitation program, and they also concluded that tele-rehabilitation offers a quick and effective option to respond to the specialist rehabilitation need for the patients of COVID-19. So now, how to execute the telemedicine based? There is some difference between the institution based and telemedicine based. The structure is the same, but the method and execution is a little bit different. So this pulmonary rehabilitation team, patient-centered team with the pulmonary medicine specialist, PMR specialist, and paramedical person like therapist, dietitian, and psychologist, etc. I believe that these are the protocol which I follow. The first consultation has to be physical one, where the patient has to attend to your OPD or your setup, and you are supposed to do the detailed examination or clinical examination. Then after the detailed thorough clinical examination, you are supposed to find out these indications and contraindication, which patients you are not supposed to enroll for the telemedicine-based pulmonary rehabilitation program. Then, as per the telemedicine guidelines, patient's written informed consent is must, where you are supposed to brief everything about the patient, what exactly you are going to do for next 6 to 8 weeks with the help of telemedicine as well as institution-based screening. Then this is a thorough outline of the pulmonary rehabilitation program, where you start with patient assessment, then patient education and motivation, patient exercise training, program evaluation and maintenance. So this is a simple assessment program where you are supposed to take the relevant history, past history, then other vital parameters, then exercise in MMRC scale, St. George Respiratory Disease Questionnaire or Quality of Life Questionnaire, along with that simple vitals like pulse, BP, saturation, and to rule out any cardiac etiology, ECG, 2D echo, and other parameters. Then after assessment, we are supposed to calculate this targeted heart rate and rate of perceived exertion. Then contraindications, just like a institution-based pulmonary rehabilitation program, these shall be the same contraindications for telemedicine-based pulmonary rehabilitation program, basically angina pectoris, unstable angina, and other cardiac diseases, etc. Then the patient's goal, the goal of the telemedicine as well as institution-based pulmonary rehabilitation program should be realistic in consultation to the patient, and after patient's assessment, unrealistic goals you may not be able to achieve neither from your side, neither from the patient's side. Then exact execution, again the patient education, then optimization of medical management, then nutritional advice, secretion management, breathing techniques, nebulization, physical re-engaging exercises, and assessment outcome. Then start with the patient education with the leaflets, then optimization of medical management, correct techniques of use of metered-dose inhalers and use of spacers. The nutritional advice is very much fundamental. The reason is that there is an increased work of breathing and there is an increased energy expenditure in the very act of breathing. So high protein, high carbohydrate diet is essential for the better recovery. Then bronchodilation before pulmonary rehabilitation, whether patient is at home or at institution, it's essential. Then secretion management, yes, before starting of the exercise session and other session, the secretion has to be removed for the better oxygen alveolar exchange, and these are all postural drainage, percussion, vibration, PEEP therapy, and airway clearance. And all these things we are supposed to teach to the patient as well as patient's relatives. Then again, breathing technique, when the patient visits at your center at the first session, then all the breathing techniques you are supposed to teach to the patient. This includes diaphragmatic breathing, segmental breathing, pursely breathing. Various breathing techniques have various indications, and according to disease pathology, you are supposed to taught to the patient. And again, the same thing, you are supposed to teach to the patient as well as caregiver. Then again, use of oxygen is very much essential. Then the physical reconditioning exercises, there is a vicious cycle for the reconditioning. The reason is that chronic respiratory diseases leads to dyspnea, leads to inactivity, reconditioning, worsening of dyspnea, disability, and ultimately death. So this physical reconditioning exercises break this cycle, vicious cycle. So again, the specificity of training, as we all know, strength training and endurance training. American College of Sports Medicine have given various guidelines, but we are supposed to a little bit modify the guidelines in view of telemedicine-based rehabilitation program. So these are the various flexibility and warm-up exercises, beginning 4 to 5 minutes. This is a video of one of my patients taken a therapy session that suffering from the COVID-19 pneumonitis. So 2 to 3 days a week and supervised, and patient can do at home without any supervision. Then cardiorespiratory endurance training. There are various dynamic exercises of large muscle group. This, as the patient is doing at home on the telemedicine or video call, the jumping, skipping rope, home, treadmill, stationary cycle or staircase training can be done. So this aerobic conditioning, jumble or simple jumping or marching exercises you are supposed to do. Frequency is again 6 days a week, 3 days a week on the video call, and 3 days patient can do at home, monitoring all the parameters. Then again, strength training, these are various group of muscle. Again, the accessory muscles of respiration we are supposed to strengthen for this better outcome of the patient. So these are various group of muscles which we are supposed to target at the beginning. Then At the home, if the patient doesn't have fancy equipment like dumbbells and all, simple water bottles can be used for the training program for the strengthening exercises. Again, the frequency will be 3 days a week, 3 days on the video call and 3 days on the without any video consultation. So total duration approximately is 5 days a week. I personally follow 3 days a week on video call and 3 days a week on from the patient's side without any supervision and 1 day rest. So this is a rehab protocol which we follow. We start with the patient education, then with breathing technique exercises, oxygen if required, and along with that warm-up exercises, activity training like various aerobic conditioning as well as strength training, etc. So I think 2 minutes more. Yes. So now the question is setting up of the pulmonary rehabilitation clinic, especially telemedicine based. So again, to set up, these are 4 things which need: infrastructure, manpower, equipments, and standard operating procedures. So this infrastructure-wise, you just need a good quality desktop along with good quality SD webcam and good quality internet connectivity. From clinician perspective and from the patient's perspective, they just need a smartphone. I personally believe that only PMI doctor is essential. No need of requirement of any paramedical staff or therapist. If you have a competent enough and if you have time to do all these rehab sessions, then from the equipment, from the basic point of view, from the incentive spirometry for the patients, then pulse oximeter to monitor the pulse as well as oxygen saturation, then simple set of the dumbbells, or simple, if the dumbbells
Dr.
are not
Harsha,
available, you can simply start with these water bottles.
Dr. Harsha, please conclude. You have, how many slides you have?
No, sir. 2 minutes are there, sir. The first buzzer is for the...
Let's finish up. Okay.
2 minutes or more, sir.
2 minutes? 2 slides? Okay.
1 and 10.
This is a question hour.
No, sir. I am exceeding? Okay, thank you, sir. All right, sir. So these are 4 or 5 slides, sir. So the practical tips, I would say that that's a technology platform. I generally use the Google Meet. Then for the patient point of view, mobile stands are essential. Then initial peer assessment has to be there under your supervision. Then you can take her to this therapist. Initial session should be 1-to-1, and after that, with the group sessions, you can conclude. So these are standard operating procedure. And this was a study we did at the Safdarjung Hospital for COVID-19 pneumonitis. Yes, yesterday Dr. R.K. Srivastava sir as well as Dr. Sundar sir has talked about this advancements in artificial intelligence. So I believe that the future is that there shall be various artificial intelligence based various apps, various therapeutic exercise based apps, and this can be very well utilized for the telemedicine based pulmonary rehabilitation program. So it's a new telemedicine is going to give a new dimension to the healthcare structure of the India. It's very much effective, and this is the opportunity we must grab it. Thank you, sir. Thank you for exciting time.
Thank you, Dr. Harsha, for covering 2 important problems like pulmonary rehabilitation and telemedicine. And you made it like giving the service to doorstep in the form of telemedicine is a good thing. So we don't have time, but I'll invite one more question. One question if you have any. Yes. Please be brief.
Thank you very much for your very nice presentation. One question simply.
Yes, sir.
Whether you see exercise, recommendation for obstructive lung disease and you see restrictive lung disease is same or different?
No, sir. The overall protocol for the restrictive lung disease is totally different, sir, where we are not supposed to give more emphasis on the aerobic conditioning exercises because the lung capacities are less. There may be a desaturation incidences we can encounter. The total protocol is different, and restrictive lung disease rehabilitation program has to be more supervised rather than telemedicine based. So I definitely discourage the telemedicine based rehabilitation program for restrictive lung diseases. Yes, thank you, sir.
Thank you so much. Thank you, Harsha. Thank you so much.
Thank you, sir. Thank you.
Next, I take this privilege to invite one of the very eminent physiatrists, Dr. Navita Purohit Vyas. She's not only a physiatrist, but also a renowned interventional sonologist. So I'm happy to invite her to give her talk. Please, Navita. So she will be speaking on evidence-based approach to cancer pain. Please.
Thank you so much. Very good morning to all. And without wasting my time, I'll start straight away with my talk. I'll be talking about cancer pain management. A lot has been talked about cancer rehabilitation yesterday, and one of the most important and most common complications of cancer is the pain. So looking about the incidence, we have seen that there are WHO says that around 2 to 2.5 million cancer cases at any given point of time in India. And by 2050, this will be around 17 million new cases in developing world. What is the prevalence of pain? Around 64% of patients with cancer have pain when they are in metastatic or advanced or terminal phases of cancer, and around 59% those who are on anti-cancer treatment, and those who have finished their treatment, around 33% still have pain after their treatment. So most of them, around 50% are undertreated. Inadequate pain relief is seen in 56 to 82.3, which is a huge number. 40% die with severe pain, and 28% they receive, only 28% receive pain and palliative care, which is a very lesser number. What are the common symptoms in terminal cancer? Pain being the most common. 70% of the patient have pain and all the other symptoms. So what are the causes of the pain? Due to the cancer itself, due to tumor infiltration, involvement of the nerves and the plexus, bony metastasis, or it can be due to the treatment, due to the surgery, radiation, chemo, or immunotherapy. Or there can be pain which is coexisting or due to other diseases. The types are visceral, somatic, and neuropathic. Why do we need to know it? Because the pharmacotherapy or the intervention, what we do, we need to know what is the type of the pain. So the patients suffering with pain, they always have this question, why me? They are in a denial, no, I don't have cancer. Why should I go for the treatment? And why should I bother my relatives and suffer on my own? Family is in guilt because they are helpless, they are not able to treat the pain, and the patient is suffering along with the family. What does it impact? It impacts on the quality of life of the patient as well as the caregiver. How do we go about with pain management? It can be done with pharmacological, non-pharmacological, or interventions. So we begin with the WHO step-ladder pattern, starting with non-opioids, weaker opioids, and stronger opioids like morphine and fentanyl. These are the opioids which can be used. We don't have hydromorphone and oxycodone in India, but we have all the other weaker and the stronger opioids. Adjuvants used in neuropathic pain, we use in all kinds of neuropathic pain, can be used in the cancer pain as well. TCAs, SSNR, SSRIs, SNRIs, gabapentinoids, and benzodiazepines. Also, when they have edema, so steroids, they help in reducing the pain as well as the disease and the edema. Bisphosphonates, if they have skeletal meds, they should be used monthly. And nowadays, denosumab 120 milligram monthly is being used. A slide about morphine, fact and myth. There are lots of myths associated with morphine, because even not only the patient, but even the doctors, when they refer patient to us, they say if we start morphine, it is the end stage of the disease. No, we should relieve the patient of pain, so morphine can be started at any stage of the cancer, and the side effects and sedation, and mostly they are bothered about the addiction. And believe me, when we are treating cancer pain, the addiction is very less. It is because they live for they don't live for a longer period of time, so addiction should not be bothered when we are treating cancer pain. Radiation can be used when they have skeletal meds, and it has been seen that there's a complete pain relief at 1 month in only 27% of patients, and out of this, additional 42% have some pain relief. But what about the rest? What happens if they are not getting this pain relief? Sometimes in prostate cancers, radioisotope can be used, strontiums, and we should also have this thing in our mind, cancer pain emergencies like cord compression, withdrawals, and also bony metastasis where the surgeries can be used, should be done. Now what next? If they come, we have used our pharmacotherapies, we have used radiation, but if still the pain relief is not there, how do we go about it? So don't give up the hope. Pain can be managed, and there's more than one ways to treat pain. So that is where the role of interventional pain medicine comes into role. So I'll discuss few cases, and then we see what can be done what interventions can be done in cancer pain. This was a case of multiple myeloma. There we can see there's a compression of L4 vertebrae over there with causing compression on the L4, L5 nerve root. He was undergoing chemotherapy, radiation, but the pain was not, there was suboptimal relief of the pain, and conservative management was given, fentanyl, morphine was given, but still he was complaining of pain. So we went ahead and did an ultrasound assisted fluoro-guided L4, L5 transforaminal block, and we can see the contrast spreading in the transforaminal area in the caudal, in the epidural space, and he got a good relief, and the pain, quality of pain till the radiation started working, this block worked, and we didn't, the need of a repeat block was not there. This lady, she came with advanced cancer, with multiple mets everywhere, and she was complaining of severe pain, surgery, chemo was all done, but she was admitted for palliative pain relief. We started with IV fentanyl and all the other neuropathic adjuvants, but the pain relief was optimal. So we went ahead and talked about ultrasound-guided celiac plexus block, and they agreed for that, and we did a diagnostic block in this. This is where we do the celiac plexus block with ultrasound guidance, and that's what the injected is spreading, and that gave relief for her. When the diagnostic block worked, then we went ahead and did a phenol neurolysis of the celiac plexus. We gave a follow-up, and she lived for four months. She went, her last wish was to go to her village and spend her rest of the life, which she did, and the need of the opioids reduced, and the pain relief was very good, and the suffering and the quality of life was better. A very unfortunate 19-year-old female with advanced metastatic breast cancer and lung cancer with skeletal mets, humerus, affecting the humerus and the whole spine. She had taken radiation for the humerus bone, but still she came back after 2 weeks, and she was having severe pain along the shoulder and along the arm. So we started with analgesic, suboptimal relief. She could not sleep. It was bothering her like anything. Fentanyl, morphine were not working. And then she became allergic. She started vomiting with fentanyl, and so opioids were not working. We had to do something. So we did a suprascapular nerve block, which gave a good relief, followed by phenol neurolysis of the suprascapular. And then she got a very good relief. She has gone back to her home. We know that the life is limited, but at least the pain is under control. This is what they wanted, she and the parents. Now, this gentleman, he was a 76-year-old from Nairobi. He came with advanced cancer prostate, and he had pain in the rectal area and also in the back pain. So he was already on IV morphine, high dose of IV morphine when he came to us. When he was referred to us, he was having the neuropathic painkillers. The rectal pain was bothering. He was not able to lie down. He was not able to sit, and he was so frustrated that the daughters, the family was depressed and helpless, and they were feeling of guilt that they are not able to do anything. If you see that there are so many lesions in the spine, he was undergoing radiation therapy for the same, and the PET CT, there's an enhancing prostatic mass which is infiltrating the anorectum and the pelvic nodes. So we went ahead and we started all these medications, but the pain was not getting better, so we spoke about ganglion impaired block, and they were ready for that. We did a diagnostic block, and we can see this is where the ganglion impaired is. That's the good contrast spread over the ganglion impaired, and then he got a very good relief, and then we did a phenol neurolysis of the ganglion impaired. And the pain reduced, and he went back to his country. He was very happy. He was able to stand, walk, and first time he asked for food. So this is a very small things, but it makes a huge difference. As we say ADL, if they are not able to eat on their own, as rehab physicians, we know what is the importance of this. So this is also very important. If the pain is being taken care of, and they are able to eat and then walk on their own, this is what we as physiatrists, and doing pain, we are making a big difference in the life of these patients. Now the last case, he had lung cancer, and he had undergone thoracotomy, and 1 month post-surgery, he was on fentanyl, but was not getting 50 micrograms of fentanyl, but not getting proper relief, and he had pain around the scar. It was a burning pricking, so it was a neuropathic pain. We did a diagnostic intercostal nerve block, and he got good relief with the diagnostic and therapeutic. We used a little bit of steroid, but then he came back. This is where we are doing the intercostal nerve block. He came back after 2 weeks, and in the emergency, and then we had to do a phenol neurolysis of the intercostal nerve, and he responded very well. So the pain relief was very good, and the chemo and radiation went off very well, and now he's free of disease and also free of pain. So what are the other procedures which can be done? We can do a stellate ganglion block in head and neck cancer patients. We can do lumbar sympathetic block for the lower GI cancers. Peripheral nerve blocks can be done followed by RF or ablation or phenol neurolysis. So we don't, I'm talking only on the physical pain, that there's the symptoms and the iatrogenic, which is caused by that. But there is so much, when we have to treat the total pain because we are rehab physicians. So we do not just treat the symptoms, but we have to deal with these things also, because along with the pain comes the anger, the anxiety, and the depression. What we see is the iceberg, tip of the iceberg. What these things are also should be dealt with. Once the pain reduces, then these things should be dealt with. So we need a multidisciplinary approach and a multidisciplinary team, which we all have. So the spiritual counselors, medical workers, the home caregivers, the physical therapists and occupational therapists. So good rehab, and not only rehab, but the spirituality and that also should be spoken about when we are talking to these patients. A brief idea about what happens in the end of the life, because they have pain. Now we cannot do any blocks, so we have to talk about sedation, because that is what is a therapeutic option at the end of the life when they are at home. We can use opioids, we can use benzodiazepines and propofol if they are admitted. Otherwise, benzodiazepines, they do a very good role. And a continuous assessment is very important because the suffering has to be reduced. And to conclude, comprehensive approach to a patient with cancer pain is important. The patient and family should always be included, whatever management we are doing, whether pharmacological or non-pharmacological. And also the interventions, they can be included at any step. It can be the first step, we can de-escalate or we can escalate the treatment. And being rehab physicians, practicing pain and palliative care, when we talk about quality of life and adding life to whatever years or whatever the weeks or months the patients have to live, we can also improve the quality of death of the patient, because that is also very important for each and every patient who is undergoing cancer pain treatment. So I would end my talk with this quote, when the world says give up, hope whispers, try it one more time. Thank you so much for listening.
That was a very nice quote, Dr. That is as well as always wonderful to listen to your lectures. And you are brought about one more part of the cancer pain, the pain intervention programs. And the floor is open for any questionings from anybody. Please, sir.
Quality of death. Okay, but as you have mentioned about the use of bisphosphonates and denosumab in the bone meds, pain due to bone meds, I just want to know what is your experience or what is the take of uses of those agents in osteoblastic versus osteolytic meds?
We have to use in both osteoblastic and osteolytic. If there are skeletal meds, it should be used.
And do you find similar results?
Yes, but we have to tell them that there can be osteonecrosis of the jaw, which is very, very common when we use bisphosphonates. So the safer one is the denosumab.
And also atypical fractures of femur and all those things. Yes. But efficacy-wise, both are equal.
Efficacy-wise, both are equal.
Thank you. Thank you for your answer.
Yeah.
Thank you very much, ma'am. Your very nice presentation. Simple, I want to ask you one question regarding the non-pharmacological management in case of carcinoma pain. So, is there any role of the VR system, that is virtual reality, to control this pain?
Virtual reality is coming in a big way in chronic pain management, non-cancer chronic pain management, but we still need some more good papers. I think so AIIMS Rishikesh has it, and Rajkumar can follow up with that. We still need good studies for the virtual reality.
Okay, thank you.
Logically speaking, it has. Hypothetically, yes.
Thank you, Dr. Navita, for the wonderful
so
speech,
much.
and it's really a nice lecture on you. I now call upon Dr. Sumalata from Aster CME Hospital, Bangalore. She is going to talk about DCS and hope for spinal cord injury. This is one another dimension of management, and I welcome Dr. Sumalata to speak. Please.
Yeah, good morning, everyone. How many of you have heard about DCS or ESCS? Can you raise your hands? Okay, what is it? Yeah, it's dorsal column stimulation. So is it a hope in spinal cord injury? Let us see. So recently, just the 30th Jan, we in the newspaper links, we saw that Neuralink has been tried by Elon Musk, which is a brain chip that he's put in the brain, and a human trial, first time human trial has been done. So it is not far that we will soon be able to help the paralyzed people, and we as physiatrists should grab this opportunity to be ready to explain to the patients, have our protocol set, and do what is required. So in spinal cord injury, the neuronal control of locomotion depends on the complex dynamic interactions between the spinal circuits, supraspinal structures, somatosensory feedback, and biomechanical properties of the musculoskeletal system. Complete spinal cord injury abolishes neuronal communication between the brain and the spinal neurons controlling the legs or the hind limbs. So my today's agenda is what is ESCS or DCS, rationale of DCS, the principles, the clinical applications, and the experiences. So what is it? It's spinal cord stimulation, and more specifically epidural spinal cord stimulation involves the surgical implantation of a small array of electrodes into the epidural space. So these are the different types of electrodes that you can see here, but the most common electrode which is used to implant is this, which is 5, 6, and 5 pattern. So it's basically a 16 paddle lead which is typically placed between the vertebral levels of T9 to L1. Although positioned epidurally above the lemniscal tract, the posterior roots entering the spinal cord at a given spinal segment are targeted. As we can see, this is the posterior part. This part is where the lead is placed. This is how it looks in the X-ray between T11 to L1 upper border. So the rationale for its use, like it started with the pain management. First used in 1967 at the thoracic level for treating cancer pain. Later used in neuropathic pain, extremities, failed back syndrome, and CRPS. And suddenly they started seeing some positive effects in spasticity in multiple sclerosis. And later, in late 1990s, they started seeing suddenly that there are some motor improvements in the spinal cord injured patients. So then the research started and the publications or the trials started. So this study shows that epidural electrical stimulation to facilitate locomotor recovery after spinal cord injury. Hind limb locomotor recovery is possible in various preclinical models such as mice, rats, cats, and dogs, because of a network of neurons called the central pattern generators. Like in this, they have explained why the recoveries or movements have been seen. So it is basically the central pattern generators in the spinal cord which helps in doing that. This spinal locomotor CPG can work autonomously without inputs from the brain and the periphery. After complete SCI, the locomotor CPG retains the ability to generate the basic locomotor pattern and interacts with the somatosensory feedback from muscle, joint, and skin afferents that enter the spinal cord, caudal to the lesion. So ESCS raises the level of spinal excitability close to generating motor output, which is reduced in people with SCI due to the severely impaired descending spinal pathways. By this increase of spinal excitability, stepping movements can be generated during ESCS even in people with complete lesions. In people with clinically complete lesions but some preserved descending fibers, which is called discomplete lesions, supraspinal voluntary adaptation of stepping movements can be achieved during the ESCS. The improvement of coordinated movements during application of ESCS is most likely not based on structural changes such as the axon regrowth, since return of voluntary leg movements has been observed in some patients after just a few stimulation sessions, and no long-term recovery of voluntary function without the application of ESCS occurs. So this is how it is. When there is a complete lesion and there is an electrode which is placed, which helps to just stimulate the motor neurons in the lumbar enlargement, and that helps in motor unit recruitment and the movements. So the central pattern generators again explained like how it helps. But in this again, the limb movement or the displacement which causes the afferents from the 1A, 2 and 1B afferents which go and give signals to the spinal cord helps in a proper regulated movements. So electrical spinal cord stimulation must preserve the proprioception to enable the locomotion in humans with spinal cord injury. So initially they said that only the central pattern generators is enough, but later they found that the proprioception is necessary for them to get the adequate movements. So and in that proprioception also, so the type of stimulation also matters. When they are just giving the tonic stimulation or the phasic stimulation, what is the difference is what this study explains. In rats and mice, the antidromic, the spinal cord stimulator induced antidromic activity is around 20 to 100 beats per second, but in humans it is 0 to 60. So whatever signal is coming from the afferents, it can get cancelled and there can be no movement or a reduced movement. So a properly placed electrode matters like how the movements are generated. So they also saw that electrophysiological mechanisms underlying cervical epidural stimulation in the adult rats. It has also found to not only have the motor recovery, but also autonomic function recovery after the chronic spinal cord injury. They tested around 25 patients with chronic motor complete spinal cord injury. And in this series, it was found to be safe and achieved numerous benefits on motor and the cardiovascular regulation. In one of my patients also, the patient themselves told that the patient never used to feel when they used to pass the bowel. But after this implantation, they have started feeling some autonomic changes and they realized that, okay, they are about to pass the bowel. A scoping review of epidural spinal cord stimulation for improving the motor and voiding function. So they have also tested whether it helps in the voiding function. In my experience, I have not noticed any voiding improvement, but the studies have shown that 5 and 2 participants respectively demonstrated improved supraspinal control of volitional micturition with the spinal cord stimulation. So it has also been studied that because the spinal cord works in a multiple ways, maybe some gene therapy or the additional medication therapy like serotonin intake will help in enhancing the movements in them. So this study for the first time employs a combination of EES facilitated locomotor training with intrathecal administration of the trans genes, and obviously these are preliminary studies, they still have to have a final conclusion. So there are predictors of volitional motor recovery with the epidural stimulation. Like not every patient will get the same movement or the same type of movement. So, but what we have seen is the time since the injury doesn't matter. So even after 10 years or 16 years also they have tested and they have found to have some improvements. So the aim of this study was to understand whether the individual's neuroanatomical characteristics or positioning of the epidural stimulation electrode were important factors which would influence the movement. The results suggested that greater coverage of the lumbosacral enlargement by the spinal cord stimulation may improve the motor recovery prior to any training, possibly because of the direct modulatory effects on the spinal networks that control the lower extremity. So even if other parameters are not working, like there is some atrophy at the higher level, spinal cord atrophy at the higher level, but if they are able to cover the motor enlargement in the lumbar area, so they measure it through various means by 3D reconstruction of the MRI and the CSF volume, which is more in those areas. They have their set protocols to assess this. And they place the stimulator around the maximum motor enlargement in the lumbar area. So they studied that when they place it a little millimeter or a micromillimeter above and below, the results were not good as compared to the exact place that they are supposed to do it. So the targeted selection of stimulation parameters for restoration of motor and autonomic function in individuals with spinal cord injury, they concluded that the tonic interleaved functionally focused neuromodulation targets a myriad of consequences from spinal cord injury. This approach indicates the sophistication of the human spinal cord circuit and its important role in the regulation of motor and autonomic functions. Like these are what you see are the electrodes, what I told, no, 5, 6, and the 5. So total 16 electrodes are there. Say it is a bipolar electrode that we have to keep, that is one positive and one negative. So depending on what electrodes that we are selecting, the movement pattern changes. So in various types, and which one suits the best to the patient, it is decided on the operating table and also post that in the clinical trials. This is one of the few of the videos that I would like to show. Like without the stimulation, the patient cannot walk. This is with the harness that we are trying to see if there are movements. This is a complete spinal cord injury post bullet injury at around D10 level. And the patient is able to walk very comfortably. This is a soldier from Iran, so he has very good endurance, and he takes around 10 rounds in the parallel bar without a break. In fact, even if it is at this stage at the exercise level, even a movement or the activity like this would encourage them more, and maybe in the further in the future, with the better protocols and guidelines, we will be able to achieve a proper movement pattern. This is one of the other patient. In the initial stages, we used to get only one-sided movement. The other side was assisted by the therapist. And the movements were very slow, but a proper stepping pattern was achieved. Later, with repeated training or the different types of protocols or the electrodes that we targeted, the movements were slightly better, but both were coming together, so we had to restrict the other leg. Other thing that we noticed is, so can I take 1 minute? The position change matters in such patients. When they are sitting, the spinal cord or the electrode, how approximate it is to the dorsal column or the spinal cord, it matters. When they are lying, it is more approximate. So even say we are stimulating at 5 volts current. So when in the lying down position, the movement that we see are different when in the sitting and when in the standing. So in the standing, the distance between the implant and the spinal cord is far away. So the voltage requirement may be more, and also we cannot fix it directly to the spinal cord. So it will have some movements. So that also matters, like why we don't get the same movements in the lying, sitting or the standing position. So the limitations is, like we are able to achieve with the harness, only walking. Standing we are not able to achieve. So it again needs more number of trials and studies which will tell us what programs will cause both standing and walking. So the spinal intelligence and consequently neuroplasticity within the spinal cord to regain motor function is still limited. So the contraindications is like any other surgery. There is no other specific contraindication only for this. So when we recommend epidural stimulation to patients, so like mutual funds, it will come with a clause that voluntary control outcomes will vary from patient to patient. Thank you for the patience.
Thank you. Sumala, thank you very much. Actually, you have added a new dimension of neuroregeneration, neurorehabilitation, and pain management. It's a good, very evolving science. We would love to see more results out of this. So we have one more minute. We invite questions from the audience. Please, sir. Okay. So, from the same institute.
Thank you. Thank you, Sumalata, and well done for starting off something like this. So my question is simply, have you seen any of your patients coming out of body weight support and walking on their own with spinal cord stimulation?
So still not.
What is the cost?
So maybe the programming that or mapping we call it, that we are placing the electrodes or choosing the electrodes may be the cause.
Yeah, but that's a learning curve. I think eventually you might hit the right one.
Yes,
What is the cost of the implant?
So the cost initially when it started at CMI, it was around 20 lakhs, but now it has come down to 9 or 10 lakhs.
Thank you.
But post-implantation, one of the patients that I have has been very diligently coming to me since 2.5 years. So it takes longer. Because in between she had pressure sore because of the long sitting. Okay. So
Dr. Abhishek, please.
Time.
You've done couple of patients. One simple two things I will tell you. The same system is now available in the transcutaneous form also. What you're doing, injection, epidural inside, the machines available to do it now, even from skin. There's a system called as transcutaneous stimulation of spinal cord for CPG. Second point, people think with this machine, they'll start moving their legs. No, it just starts central pattern generator stimulation. You can't move your leg, but you can walk with the harness. Third thing, all patients with D8 below can be trained to walk with conventional therapy and KFOs only. So it's only useful if it can make a person walk from D1 to D8. The Zurich group has shown 4 patients with Asia A, C7 and C8 who are able to walk 10 steps. But take my word for granted, if this machine can make a person walk from D1 to D8, it's of any use, because D8 below, all patients can be trained in 3 months' time with conventional therapy.
So one of my patient was actually a cyst with long-term, long cord involvement with triplegia. Okay. So that lady also showed a good improvement and good trunk control when sitting.
Thank you. Thank you, Dr. Abhishek, for sharing your experiences. And thank you, Sumalata, you have covered so well. Thank you so much.
Sir. Thank you.
So next is, we have another lady physiatrist, Dr. Gita Handa Thukral. Okay, she will be speaking on, this is a very important topic for her, foot rehabilitation, the role of orthotics. So, Dr. Gita, please.
Good morning, respected chairpersons and dear delegates. Today I'll be speaking on foot rehabilitation and role of foot orthotics. This is almost always the last point in anybody's slide when we talk about foot rehabilitation or any condition of the foot. And it made me think about what can we do about it and how can we improve our prescription. So coming to the slides, once I started my journey, there were questions like when to prescribe, who will prescribe it, how to prescribe, where to get it from, how to use it, follow-up and maintenance, change in prescription, and when to stop using it. So these are the questions which we always face while dealing with the patient. So mostly when we prescribe, apart from the diabetic foot, which you have seen, and there are workshops also conducted, there are other conditions like foot pain, foot malalignment, there is foot muscle weakness, there is foot instability, then foot movement restriction is required or any assistance is required, or we need to alter the weight bearing or the limb length and there is a deformity which needs to be accommodated or modified. So foot orthosis, as we know, there are stock available orthoses which are over the counter. There are prefabricated like silicone insoles in different sizes are available. There are custom-made orthotics. Example like specific measurements based fabrication is possible where you just give the shoe size and you can get it accordingly modified. And prescription-based custom orthotics, that is, which is custom molded after taking the patient's foot impressions by different ways. So there is a consensus key statement, and they have said that prescription custom foot orthosis may be medically indicated and essential, or may be useful, or may have some adjunctive role, and may not be useful at all. So accordingly, we can prescribe, and we accordingly work on prescribing the foot orthotics. How to assess the foot and the footwear? We all know history and examination, which already many speakers have talked about, is essential. We do static assessment of foot, weight bearing and non-weight bearing. We do dynamic assessment of foot and gait analysis, and it can be instrumented with use of various machines and devices. You all know quite a lot about it, and I'll be touching in brief some points in between. So for examination, it is important to do the range of motion assessment, position of the ankle joint, rear foot complex, forefoot, rear foot relationship, do the muscle strength assessment, do the evaluation of the stance position, do the clinical evaluation of the limb length, do the gait evaluation either clinically or with some instruments, and assess the position, range of motion, and quality of spine, hip complex, knee complex, fifth ray, first metatarsal phalangeal joint, other MP joints, cons, callosities, ulcers, etc. So we keep a note of it, and we can make a chart and note down the important points. So for footwear, footwear assessment is also important. So we have to look for wear and tear of the outsoles, look for deformations inside the footwear, look for the preferences which the patient has and why they have those preferences, and changes over a period of time which the patient has experienced. Who will prescribe it? A wide range of available off-the-shelf devices are available. Off-the-shelf customization is also available, and custom-made orthoses are also available. And there is no data available who will prescribe it, but it is essential for us to know who has prescribed it earlier and why they have prescribed it so that we can give our prescription accordingly. And prescription points are orthosis type, correction type, arch fill technique, cast modifications, any shell material which needs to be modified, shell modifications which needs to be done, and cover material which can be used. So minimal prescription requirements are, first is functional orthosis, where we need to know the type of material to be utilized, the cast balancing techniques which we use like intrinsic correction or rear foot or forefoot posting if it is required, and depth of heel seat. And we can also give accommodative orthosis when we don't want to mobilize or correct the foot. So there also we need to choose the material. We have to see the location of the lesion or areas of pressures to be accommodated or off-weighted. So modes of modeling of feet for the category 1 are that modeling of the foot is done in the subtalar neutral position. That is, the subtalar joint is manipulated in a way that you maintain it in a neutral position and then take the cast. And in the category 2, the modeling of the foot is done in a natural position, which is weight bearing, and we try to accommodate whatever is there, and we try to accommodate the deformities or try to redistribute the weight when we want to offload it. Here we are not trying to do the subtalar neutral position. So for the subtalar neutral position, that is trying to correct the foot, we hold the foot in a position where we put our hands on the side of the sulcus area on the 4th and 5th toe, and the cast may be obtained either in a supine or a prone position. And we can also similarly do this in the same position only, the computer imaging, and take the cast accordingly. So this is in detail describe the subtalar joint neutral position where the task can be taken, and we put our fingers along the sinus tarsi on one side and navicular tubercle and try to correct it so that the foot is aligned with the rear foot. And accordingly, the patient is given the cast. In the accommodative casting, there are different varieties available. Weight bearing and semi-weight bearing casting can be done, and computer and mechanical imaging systems are there which reproduce the actual foot shape and contour in a weight bearing or semi-weight bearing position. And there are many common customizations which you all know. There are forefoot extensions, post-flaring, flanges, lens, cutouts, cast fill and accommodations. Location of the lesion also affect the different modifications. And there are different patient informations which are needed, like shoe size and width, heel height, heel lifts, etc. And there are biomechanical data which also affects our material choice and the footwear choice, like weight, age, activity level, occupation, and diagnosis. And previous orthotic use is important, and systemic diseases and habits are also needs to be ascertained. So relevance of prescription has been questioned. There are no defined clinical guidelines. The initial reliance on root model of foot assessment and biomechanics was not considered sound basis for prescription. Personal experience and experience-based prescription is most often practiced, and therefore logical understanding and prescription of foot orthosis is to be practiced. So here, relevance of technology is there. We have 3D foot scanning, we have foot pressure analysis system, there are foot pain index available, which is more used than complicated biomechanical systems like foot posture index, and newer technologies are in pipeline to assist in different stages. So custom foot orthosis, which is most commonly now in use, is foot orthosis, which are the pieces, inert pieces, which work either psychologically, that is by a placebo effect and comforting, or mechanically by altering the reaction forces at the foot orthosis interface. And mechanically, they can alter the kinetics and the foot orthosis interface by virtue of three variables, that is their superior surface geometry, their load deformation characteristics, and their frictional characteristics. And there are biomechanical considerations which are given by the Kirby, where they say mainly the main thing is the pressure principle, where force divided by the area of application defines the pressure, and we can redistribute the pressure. The more the area available, the less the pressure, and accordingly we can modulate the different modifications. So there are different types of inserts which can be used to balance the joints of the foot in the most desirable position for weight bearing, and it compensates for any malalignment caused by deformity between the leg, foot, and rear foot, and it should be placed in a subtalar neutral or a position of maximum external rotation of the foot or eversion at the mid-tarsal joint. So there are different prescription modifications available which I'm not going into the detail of. We should be knowing about it, about different modifications, but grossly, which you can see in this table, most of the modifications are focused around the pronation correction. For example, press planus, there is pronation correction required. Metatarsalgia, there is more of accommodation required. In Morton's neuroma, there is again pronation correction required. In tendinitis also, there is initial immobilization followed by pronation correction. Then posterior tibial tendon dysfunction, there is again pronation correction is required. In patellofemoral joint syndrome, there is also pronation correction required. So most of these things which you see require the foot to be in a better biomechanical space so that there is less loading on the foot and there is less dysfunction of the foot. Similarly, for the iliotibial band syndrome, pronation correction required. For limb length discrepancy, we give heel lift and correct the pronation. And inflammatory arthritis, we do accommodate the whole foot, but we have to give it in a proper supportive posture. In the pes cavus, though, there is a custom arch support required as per the arch of the foot. And in the plantar fasciitis also, we give pronation correction, and here we give some deep heel cup also. So these are the basic guidelines which help us define what kind of a prescription orthosis we need to give. And there are different modalities like pedobarography which is available. There are traditional ways of taking the measurement, and then there are other ways of taking the measurements, like we have custom molded foot orthosis using molding platform and thermal molding. This is the material which the machine which we have in our department, where one of the, this is used to take the measurement. This is used to thermomold the insoles which are prefabricated like this, and then we cut it around and fabricate it as per the patient's foot. Similarly, we have a mobile-based approach also, where we take photographs with the mobile. So this is the project which we did with the DBT-funded project with the startup, where they had developed this mobile-based program, where we used to take the photograph and then advise for any modifications, and they used to 3D print that. So this was the way the things were progressing with the mobile-based approach. And the user flow was there so that the patient, when comes to us, gets the thing made and delivered to him, and which can be repeated as per the requirement. And it was using computer vision, machine learning, surface remodeling, and 3D printing technologies. So in the custom orthotics, we have a bottom 3D printed TPU and upper layer, which was EVA, Poron, or Plastazote, depending upon the requirements. And coming to different materials, we had blue Poron, Spenco, Poron plus Plastazote if required, and there are other materials also, and EVA is the most commonly used material for making the foot orthotics. So these are the other type of equipments which are used for making foot orthotics and measuring the foot parameters. And these are some other companies which have come out with new innovative foot type insoles which are available in the market. So coming to the end of my topic, Establishment of foot rehabilitation clinics can help in better management of patients needing foot orthosis. It is a time-consuming, dedicated process, and the results are evident instantly. Physiatrists can do a great work with dedication, and excellent results are guaranteed. Availability of basic equipment such as foot scanner, mobile phone acquisition images, 3D printer, or thermoforming machine, custom moldable insole material is needed for setup. Repeat orders can be executed in 3D printed modules. Most of the modifications can be done on the desktop with suitable softwares. It helps in serving the patient better and provides instant satisfaction of service delivery. And pain relief is mostly 80% with proper custom molded footwears, and recurrence, it prevents recurrence also as per our study at AIMS. Thank you so much.
Oh, thank you, madam. Thank you for a wonderful talk. There is always a difficult talk for the students to understand, analyze the biomechanics, all the issues with the foot, and you made nicely presentation. One questions from the audience, please. I mean, there are two hands up. Okay, Ganesh.
Namaskar, madam. It was a very nice presentation. Just wanted to know that you have compared the custom-made foot orthosis. Wanted to ask that in your practice or in literature, what does it say that if ready-made foot orthosis or insoles are taken, how much of the patients does it relieve? Is it 20%, 30%, or it's you prescribe custom-made 100% to your patient?
Yeah, actually, as per my practice, I've seen that patients who take over-the-counter silicone insoles are never comfortable with it, and they don't like it. So most of the time, I change them over to the custom-made orthotics, and they feel much better after taking the customized insoles. That's my personal. And we did the study also. So in that also, we found that they are much more usable, and much more patients' improvement is seen in case of customized insoles.
Thank you, madam. Thank you. Okay, sir, please proceed.
Thanks for your comprehensive presentation. I just want to know a small thing. In neuropathic foot, which is the material of choice for insole?
Poron is the most important, because poron is the one which is, a similarity to the microcellular rubber which we use, and poron has a much better quality, much better than even microcellular rubber. So poron is the most commonly used, and if we want to give stiffness, we can add other layers. So we can make it multi-layered if we want to add stiffness, otherwise poron is the best.
Thank you for the wonderful talk,
Thank you
Dr.
so
Geeta.
much.
As Dr. Geeta and as to go for the next session, to start the session, this program is almost complete in the other gallery, so I request to receive the honors from the chair. Please.
Thank you, Dr. Geeta. We have another very interesting topic, and it is coming up, Evolving Science Regenerative Therapy in PMR by Dr. Sudhir Mishra, Additional Professor, KGMU, Lucknow. Sudhir Mishra, please.
Thank you, organizer, to giving me opportunity as well as a topic to present myself. And this topic will be based on more of practical thing, and based on my patient feedback and what feedback I got from the other societies. As I am presenting this type of topic in last 6 months, third time in different platform and with different society. So Good morning, all of you. My topic is regenerative medicine, regenerative therapy. This is the ideal regeneration, which is given by the nature. Thing which is there anatomically as well as physiologically, it should be regenerated. That is ideal regeneration. So this image itself clear the thing. This should be the future of our medicine or rehab medicine. There are three three things we have to remember. Regenerative medicine, it seeks to replace tissue or organ that has been damaged by age, disease, trauma, or congenital issues. Then regenerative therapy is a therapeutic application of regenerative cell like stem cell, PRP, dextrose, prolo, and other regenerative therapeutic agents. And then regenerative rehabilitation, where we are working, is integrate regenerative technology with rehabilitation clinical practice to restitute function and quality of life of individual with disability, which was otherwise irreparable. From first, regenerative medicine, our target is regenerative rehabilitation, but path is through the regenerative therapy. So my topic is regenerative therapy. These are the, as previously slide, you can see regenerative medicine treatment include PRP, prolotherapy, lipogems, and stem cells. Few mechanism of action of regenerative therapeutic agent, which has been used. Bone graft, it has osteoinducive, osteoconductive, or osteogenic effect. It stimulates new bone formation, but it does not affect regeneration of muscle as well as tendon. Then autologous blood, PRP, autologous condition serum. They are my highlight of my presentation. Then they deliver the growth factor and stimulate the repair. And stem cell, which is becoming very popular, and it is believed that they replace the dead or dying tissue by improving the regeneration capability. PRP, I think this was already been discussed in first session of today's first session. So any question will be related with that. I'll go in speed in this thing. Why PRP? It has many growth factors. When it is called PRP, when your platelet concentration is 5 to 7 times or 1 billion platelet per microliter. There are three types of PRPs, being platelet derived group available PRPs. Pure platelet rich fibrin, then leukocyte rich and leukocyte poor. Difference between leukocyte rich and leukocyte poor is this filter. This is a filter which can convert leukocyte rich to leukocyte poor. This is a method of preparation. There are two methods. Gel method and gel method, single times centrifugation and twice double soft and hard spin method. We can discuss it later on also. Then it has clotting, the platelet get activated, release the growth factor. Approximately 70% of growth factor get released within 10 minutes and remaining in 1 hour. This is the thing which has been, I was very interested in this thing, autologous condition serum. This is the orthokinetic therapeutic serum, therapeutic method. And this, in PRP and this method is almost same, instrument is same with slight difference. It includes collection of 50 ml of blood in chromium sulfate coated glass beads. It should be there. Then it is being incubated and heated at 37 degree for 12 hours or 24 hours. If you don't have incubation machine, you can store at 24 hours it will get automatically get heated. What this does, it produces interleukin-1 receptor antagonist by WBC, which is pro-inflammatory. So once the receptor antagonist get generated, inflammatory effect get reduces. Then centrifugation at 12,500 revolution per minute for 10 seconds. Then after that, same, it is separated. Supernatant serum is separated. Like in PRP, we take the buffy coat. In this, you collect the supernatant serum and then filter it by 0.22 microfilter, and that is been injected over the musculoskeletal pain area. This is the slide showing the difference in PRP and orthokines. In orthokine, we use serum. In PRP, we use the buffy coat. This is in previous study. It is found very effective in lumbar, mainly in the radicular pain or related with the spine. And one more article is being published last month that tried this in ONE also, but I have yet to be do more research. Then come to the prolotherapy. You know that dextrose prolotherapy is being used more commonly, and there are many prolotherapeutic agents are being used, but dextrose is most commonly used, and it is thought that it increases the growth factor. But we had done 3 studies in our institute with this prolotherapy, and in ONE, plantar fasciitis, as well as tennis elbow. This is effective, but effect doesn't last more, and you require a multiple injection compared to the PRP. This is a study, and you can see the prolotherapy has been used for TM joint arthritis, knee osteoarthritis, back pain, sacroiliac joint pain, and so many things. Then we come to the stem cell. What is a stem cell? Stem cell is had capacity to differentiate multiple type of cell, and it itself get help in regeneration of the damaged tissue. But what is the problem with stem cell? Stem cell to collect in adult patient, we required the stem cell from the bone marrow, and that is pain to collect a bone marrow required hospitalization as well as a painful procedure, required anesthesia, and all those things are required. But once you collected the bone marrow, there are 3 methods, 3 places from where you can collect the stem cell: the bone marrow, then lipoaspiration, and isolation from the tooth pulp. I have experience with, not myself, but with the other colleagues, bone marrow as well as liposuction. Method is almost same as we used in centrifugation and other things. In bone marrow aspiration, you collect the bone marrow, then centrifuge it. You can see there is 2 tubes in 2 number. One is double spin method, and which is on your left. Another is single spin method. Single spin method means they had used the gel to separate, as similar to the PRP. That is, gel is known as Ficol gradient centrifugation. Then after the collecting the stem cell or that buffy coat, you have to culture it, expand it, and after what is the criteria when it is told to be stem cell is matured? There is image is not that clear. The CD4 count, there 2-3 CD4 count, there should be present in that. Similar thing is with the liposuction also. In that you collect the fat, then clear it by separation. The upper adipose tissue is being again collagenase 1 digestion is done, and then centrifugation, then stem cell get collected, and same method. expansion and characterization, means once the marker developed, then you can administer over the required site. When you should not do the stem cell? When there is a systemic or uncontrolled infection, poor functional capacity, end organ damage, psychological affecting the ability of patient, and melodoplasia of bone marrow. Then autologous blood injection. This was used in the past, not in being used the present time. In this, you have to collect the blood, infuse over the site. It causes a lot of pain. So the thing is not being used, obsolete. To conclude, understanding the principle of regenerative medicine is essential, and incorporate them into the rehabilitation medicine with the help of regenerative therapy is critical in order to deliver validate science into the clinical option that will allow you to build a model of care that can have potential to change the word care to cure. It should be remembered, we have to convert our care service to cure. And the way is regenerative therapy. Thank you.
Thank you, and right on time, sir. Thank you for finishing right on time, Dr. Sudhir Mishra. Is wonderful. And really, the end point to the patient, I'm all right. That's what he wants, whether you give whatever the therapy he wants.
Yeah.
That area of medicine, really nice. The floor is open to question.
A very nice presentation.
Thank you, sir.
Simply, with the help of regenerative therapy, the stem cell, how many patients has cured?
Sir, stem cell is being used used for CP patient, stroke patient, SCI patient. But as far as my experience is concerned, and my experience with other person, other society person is concerned, they had not been helpful in stroke and TBI and other things. They have been used and found successful in musculoskeletal disorder as well as in the osteoarthritis and other degenerative. In the degenerative, not in the neurological condition.
Thank you.
Injury?
No, no. Failure is my main focus is use the thing for the musculoskeletal disorder at present. Whatever comes in the future,
Dr.
we'll see at that time.
Thank you, sir. Dr. Navita?
Yes, ma'am.
Thank you, Sudhir. So,
Yeah.
my question is, you have very well elaborated all the regenerative therapies. So, in your practice, or what is your experience, which is the best for degeneration, ONE? What would you prefer?
Ma'am, regeneration of ONE, we had doing the study as well as done study with PRP as well as this prolotherapy. At present, prolotherapy is giving good response, but the other association where we had delivered the lecture and discussed the things, stem cell is found more superior in cases of OA, but I had not have my own experience. By next year or in 2 years, I'll come to know what is it there. But even if we do the PRP properly, we can have better result with PRP also, because stem cell is painful. That thing is that main.
So, what is, when you say BMAC, when you say stem cell, and you say expansion and then go for the CD4, do you do that? Do you really do that, or is just the BMAC which you are the BMAC?
Actually, few companies are there. They are promoting. You give the patient, you withdraw the bone marrow and give.
Experience. Are you doing it? Are you really going for that CD4?
No. This is the method. We are not I had not used also, but this is the method by company people. I don't know whether they are doing or not.
Thank you, Dr. Sudhir. Thank you, Dr. Navita, for it's a wonderful topic and a brief overview of the regenerative medicine. Now I call upon Dr. C. Ramesh, Professor in the Department of Sports Medicine at Chettinad Medical College, to give a topic on cardiopulmonary exercise testing. Dr. Ramesh.
Good morning, respected Chairperson, delegates. Thanks for opportunity. This is my contents of the talk. Cardiopulmonary exercise testing has emerged as an important clinical tool for assessing exercise capacity and predicted outcome in patients suffering from heart failure and other cardiac condition. It is a non-invasive dynamic physiological test that permits evaluation of peak exercise capacity and submaximal exercise capacity. It evaluates integrative exercise response between pulmonary, cardiovascular, and skeletal muscle system. CPET application in patient management is growing due to inability of the resting pulmonary and cardiac function testing to predict the exercise performance and functional capacity. Current clinical implication, evaluation of undiagnosed exercise intolerance for the objective determination of functional capacity and impairment. CPET machine involves the measurement of respiratory oxygen uptake, carbon dioxide production, ventilatory measures during symptom limited exercise test. This is a cardiopulmonary exercise test machine using a cycle ergometry. A non-rebreathing valve is connected to the mouthpiece with a continuous ECG and blood pressure monitoring. Resuscitation apparatus in hand. Physiology of exercises. Peak exercise capacity is defined as the maximum ability of cardiovascular system to deliver oxygen to the exercising skeletal muscle and the exercising muscle to extract oxygen from the blood. This system delivery to the oxygen and to the metabolizing cells, then get back the waste products in order to maintain the physiological milli-interior. Consequently, the exercise tolerance is driven by the following factors: pulmonary gas exchange, cardiovascular performance, peripheral vascular disease, and skeletal muscle system. This is aerobic energy system. It resides in the mitochondria. Oxygen-dependent glucose metabolism. The glycolysis is a central metabolic pathway in which glucose is converted into various metabolites, and in what happened in aerobic energy system, the glycolysis occurs, pyruvate enters into the Krebs cycle, oxidative phosphorylation occurs, electron transport chain. Advantage is more ATP production. What happened in the absence of oxygen, the aerobic metabolism takes place in the production of lactic acid. Pyruvate is converted into lactic acid. Factors determining the exercise capacity: pulmonary factors, cardiovascular factors, metabolic factors. Pulmonary factor, tidal volume, respiratory rate, and minute ventilation. Minute ventilation is equal to tidal volume into respiratory rate, whereas alveolar ventilation is equal to tidal volume minus dead space into respiratory rate. Heart rate maximum is achieved just prior to total exhaustion and physiological end of the individual. The heart rate linearly increases with the VO2 max. Predicted maximum heart rate is 220 minus age. Cardiac output, stroke volume into heart rate. Stroke volume is the difference between end diastolic volume minus end systolic volume. Resting cardiac output is approximately 4 to 5 liters, but during exercises can reach up to 20 liters. Systolic blood pressure, this is normal below 25 and diastolic normal below 85. This at rest, 15 to 20% of the cardiac output is distributed to the skeletal muscle. During exercises, 80 to 90% of the cardiac output is selectively delivered to the working skeletal muscle. This is normal. Skeletal muscle releases only 1,100 ml, but here exercises 20,000. So the myocardial blood flow increases 3 to 5 times with the exercises. Then come to VO2 and VO2 max. The most widely recognized measure of cardiopulmonary fitness is aerobic capacity is defined as physiologically as the highest rate of oxygen transport, that is normally 3.5 ml to 4 ml per kg per minute. Maximum exercises, it went up to 20 to 97 ml per kg. Carbon dioxide production normal 2.8 ml per kg per minute, at rest up to 35 ml per kg per minute during maximum exercises. This is an anaerobic threshold, ability to exercise 80 to 90% of the aerobic capacity. Normally occurs 60 to 60% of the VO2 max. They see the curve. This is x-axis represented as VO2 max. This is lactate concentration. This is yellow is untrained. This is red is trained. See, trained, what happened? The lactate threshold occurs when the maximum attain maximum VO2 max here. What happened in untrained? See, lactate threshold occurs even below 50% of the VO2 max. Metabolic factors lactase plus bicarbonate is equal to carboxy acid, lactate and water and carbon dioxide. Normal blood lactate level is 1 millimole per liter. What is ABLA? ABLA onset of blood lactate level exceeding 4 millimole per liter. ABLA is also defined as a point at which the minute ventilation increases disproportionately with the VO2 max. This is ABLA, this is the minute ventilation. See, at the reach of ABLA, the minute ventilation is disproportionately increases. Respiratory exchange ratio, the ratio of carbon dioxide produced to oxygen consumed, quantifies the macronutrient. Average is 1.0 per carbohydrate, 0.7 for fat, 0.82 for protein. Oxygen pulse is equal to VO2 bar HR, normal 2.5 ml to 4 ml per beat. At exercises, 10 to 15 ml per beat. Fick equation states that oxygen uptake is equal to cardiac output times the arterial oxygen and venous oxygen content. VO2 is equal to SV into HR into CaO2 minus CvO2, and one metabolic equivalent is the resting uptake in sitting position equals to 3.5 ml per kg per minute. Fick exercises at maximum exercises. VO2 max is equal to SV max into HR max into CaO2 max minus CvO2 max. VO2 max provides a quantitative measure of person capacity per aerobic ATP resynthesis. Maintains intensive activity longer than 4 to 5 minutes. High VO2 max represents the integrated high-level response of diverse physiologic support system, that is involved pulmonary ventilation, hemoglobin concentration, blood volume, cardiac output, and peripheral blood flow. This is VO2 plot occurs at near exercises healthy human, and it is recognized as the best evidence of VO2 max. However, in clinical setting, a clear plateau may not be achieved before symptom limitation of the exercise. This is an indication for a testing. This is a contraindication for a testing. Proposed criteria: ventilatory function, pulmonary artery pressure, aortic dilatation, arrhythmia, saturation with exercise. Exercise testing protocol: exercise testing usually done on submaximal intensity. Various studies have been conducted using step and ramp protocol. Traditionally, cycle ergometer and treadmill have been used. Depending on the equipment used, there can be variation in testing parameter. 85% achievement of predicted 220 beat per minute per age. RPE more than 7. This is a Norton protocol, asked and bruise. In an athlete, we follow a treadmill bruise protocol. Then the patient has got mild or congestive cardiac failure, we preferred a Norton protocol. This is a optimum cycle functional assessment bicycle between 8 to 17 minutes. Bicycle work is quantified in watts. Monod principle: initial workload patient with congestive cardiac failure 20 to 25 watts. Increase 15 to 25 watts per every hour. Variable depending on protocol used. So this is an indication for a termination test. So maximum and submaximal exercise tests are conducted periodically in athlete for Department of Sports Medicine. My team of doctors train in sports and exercise science. Thorough history and clinical evaluation of both general and systemic examination with the history focus in American Heart Association cardiac checklist. So this is a reason for test is functional aerobic capacity, national level swimmer, age 26, 170 centimeter, 65 kg. ECG, spirometry done normal. There is no obstructive and respiratory. Restrictive Menoric cycle protocol is used. Participant was able to exercise 7 stages out of 10. VO2 max predicted is 41 ml per kg, but he achieved 42.7 ml. RER achieved 15 minutes. RER achieved 15 minutes. Workload is 176. And maximum heart rate is 221 beats, which is 113% of predicted maximum heart rate. So this interpretation: cardiovascular fitness reflects maximum amount of oxygen consumed during each minute. The individual value can range up to 10 ml per kilogram per minute in a cardiac patient to 90 to 80 to 90 ml per kg per minute. This is a average general population, improves with training and decreases with age. This is Paralympic Games, or world second largest sporting event. An athlete of different eligible physical impairments are allowed to participate. There are 27 different sports on Paralympic region. Some of them, this athletic event include 100 meter, 200 meter, shot put, discus, high jump. Sporting events, wheelchair, basketball, wheelchair, ruby, adapted tennis are being popularly played in Paralympic event. World Para Athlete classification categories, according to International Paralympic Committee, impaired muscle power, impaired passive range of movement, limb deficiency, leg length difference, short stature, hypertonia, ataxia, athetosis, vision impairment. Athlete visual impairment participate in sports like para-archery, para-athletic, para-cycling, para-equestrian, judo, para-rowing. Intellectual impairment, athlete with intellectual impairment will compete athletes like swimming and table tennis. Physiological profile and correlation between VO2 max and match distance running performance of soccer players with visual impairment. The aim of studies were to determine the differences in VO2 max between soccer players and sedentary men with visual impairment. The running performance of soccer players during matches were measured. The results of this study showed players with visual impairment have significantly greater value VO2 max than sedentary men. Becoming a Paralympic champion, analysis of the morpho-functional abilities of disabled female athlete. An exercise test to exhaustion on a cycle ergometer was performed 3 times a year on a cross-country disabled female skier over a 10-year period. The morpho-functional level, when enabled the athlete to compete for gold medals with Paralympic Games, best reflected in the results obtained by VO2 max test. So this is my take-home message. The ability to perform exercise involves the integration of multiple physiological systems. Cardiopulmonary exercise testing remains a valuable modality in clinician evaluation. Measurement of maximum oxygen consumption provides an objective and reproducible indices of maximum exercise capacity. CPET helps in determining a high individualized training intensity zone in elite sports person for prescribing a structured exercise program. My references. Thank you.
Thank you very much, Dr. Ramesh, for keeping time, number one. Number two, you have covered in depth about the CPET, cardiopulmonary exercise testing. That is the backbone of exercise prescription, especially in PMR and sports medicine practices. You have covered so well. Actually, everybody, every physiatrist, every sports medicine specialist must learn doing by themselves and prescribing based on that. That's a very important thing. Now the floor is open for questions. If you have any or comments. Please. Microphone, please.
Thank you, sir.
Our ejection fraction is 45%, and having the dilated cardiomyopathy, she wants to take part in the working sports. Is it possible for her? How you will test?
Sir, I got experience in athletes, sir. I don't have experience in existing cardiopulmonary disorders, and also in the old age group, especially the ejection fraction is 45 more. I don't have any experience, but the opinion should be obtained, pulmonologist's opinion should be obtained, and this cardiologist's opinion on resuscitation apparatus, everything by the hand. If this test is mandate, then with equipped all things we can proceed with the test.
She participate.
I don't have that. I am working in a sports institute, sir. I think the pulmonologist. I think the pulmonologist and the cardiologist department, I will do with this type
Thank you very much. Okay, Abhishek, please.
To answer your question, we can do a limited testing for people who have low EF. It's been recommended by American Heart Association.
Thank you very much.
Thank you, sir. Thank you.
Thank you very much.
Thank you.
So, thank you, Dr. Ramesh. May I invite all the speakers of the session 9 Dr. Harsanan, Dr. Nabita, Dr. Sumalata, Dr. Sudhir Mishra, Dr. Ramesh, please be on the stage to please come to the dais for the felicitation, please.
Okay, okay. So, next, sir, thank you, sir. Next, I request Professor T. Jayakumar, sir, to come over the dais to honor the chairpersons, Professor Tirunavakarasu, sir, and Ajay Joy Singh, sir. Thank you, Professor T. Jayakumar, sir. Thank you, chairpersons. The next scientific session 11, I welcome Professor Edmund D. Cotto and Dr. T. Ranganathan to come on the dais. Welcome, sir.
This session is mostly related to neurorehabilitation, and I think neurorehabilitation is an area where most of us face a lot of difficulties and even frustration in managing these patients and in getting good outcomes. So we'll start off the session now. The first speaker, I call upon Dr. Sandeep Dole, Associate Professor, All India Institute of Medical Sciences, Bibin Nagar. He'll be giving a talk on neurofunctional interventional approaches in neurorehabilitation.
Thank you, sir.
Dr. Sandeep.
Good morning to all of you. Today, I will be speaking on neurofunctional approaches in neurorehabilitation. So we all know that these approaches are play important role in management of various neurological conditions to improve the function after the impairment and activity limitations. There are some approaches like PNF, NDT approach, roots approach, Bernstrom approach. These 4 approaches are basically old sensory motor approaches, and there are some task-oriented approaches like motor relearning program, CIMT, bilateral training program. So in order to understand these approaches, we should know what is motor control, how movement is get controlled. So there are some motor control theories that explain the motor control. So first, there are some like reflex theory, hierarchical theory, motor programming theory, dynamic systemic theory. So in reflex theory, they said in early 1990s, Charles Sherrington said every movement is due to the stimulus or sensory stimulus. If we touch any hot object, we'll withdraw the limb, hand, because of the withdrawal reflex. So reflexes are the building blocks of the complex behavioral. But he doesn't explain how spontaneous or voluntary movements acts, or how single stimulus cause variety of those responses. Then hierarchical theory comes. In this theory, they explain that lower levels are controlled by the higher levels, and there is a strict vertical hierarchy. Like brainstem and spinal cord control some spinal neural networks, they can cause locomotor rhythm without any sensory or any feedback or any CNS control. And they introduce the concept of central pattern generator that can able to produce movement like walking and running. These can be modulated with sensory stimulus. And this theory emphasizes on the capacity of relearning, and the therapy should be include training of key movements rather than focusing on muscles. And then comes dynamic system theory. It's basically any movement is depend on the 3 factors: individual, environment, and task. Like there are individual constraints like cognition, action, perception. Like it's also depend on the task, what kind of task, like stability or mobility or environment. There are some regulatory, non-regulatory factors, like shape of the object is a hierarchical model. If you see these theories, most of the old like NDT approach, Bernstrom approach, and all the old approaches, roots approach, they are primarily based on the reflex hierarchical theory. But task-oriented approach, like motor learning and other CIMT, they are basically based on dynamic system theory. So in roots approach, he uses various facilitatory and inhibitory stimuli to increase the tone or decrease the tone, like eyes brushing over the muscles. Then proprioceptive stimuli like manual joint compression, quick stretch, tapping, and to decrease the stone, slow rhythmic movement, neutral warmth, maintaining stretching. In NDT, they emphasize on to normalize the muscle tone and inhibit the primitive reflex, and by, to facilitate the normal postural relaxation. They use various inhibitory techniques like weight bearing over the affected limbs and use of various positions. In PNF, they describe various mass movements that are diagonal in nature, and they use this diagonal movement to facilitate normal movements. They uses, if you see, we do various kind of movement in which are diagonal in nature. So they use unilateral always and bilateral movement also. In Burstorm, she explained various stages of the recovery after the stroke, from plasticity to isolated coordinate movements. And she uses this synergy to get isolated coordinate movement with along these stages. In CMT, there is a forceful use of unaffected hand, and there is constant on affected. There is a use of unaffected hand and constraining of unaffected hand, and there is a modified version also. Then in that there is a decrease in duration. Then bilateral training technique, we have to practice the same activity with both upper limb simultaneously, and there is a proposed hypothesis that activation of intact hemisphere will activate the damaged hemisphere, as there is a connection to corpus callosum. So one of the most important approaches is motor relearning approach. It's a task-oriented approach, and basically there is a relearning of motor control. In this approach, there is a training of most real-life activities like walking, sitting, standing, and there are 4 stages. First, we have to analyze the tasks, like in standing, we have to observe the patient, we have to analyze, we have to see is there any missing component, like if the patient having quadriceps weakness, then we have to practice that missing component, and then practice the task. And there is a transfer of learning in 4 stages. 4 stages means we can change the environment, we can change the self-monitored training we can give, we can give advice relative to train, so we can include the relatives. So, and important point to consider that we can do entire task, or we can broken down task into various components to make the motor to practice. We can give visual or verbal feedback and instruction and manual guidance, but this should be decreased over the period, and passive movement should be limited, and we can alter the speed to increase the variety. They have given the guidelines for various, for 7 daily functions like upper limb function, orofacial function, sitting, standing and walking. But they have not considered spasticity and severe cognitive deficit patients. So practice doesn't make perfect, rather it comes to motor engram. Perfect practice makes it perfect. So this activity, overhead activity, using pulley should be avoided instead of having the spasticity. And instead of that, rock the baby, that abduction, adduction movements can be done. If you see the literature, there is one systemic article showing that Bobat is not superior approaches in stroke, not superior to other approaches, and no evidence is available to superiority of any approach. And there is one article showing the NDT was not effective in care of stroke patients. So, and there is one review article shows task-oriented approach based on systemic model is proposed and contrasted with traditional NDT approach in CNS dysfunction. So in this, another systemic review article shows task-oriented rehabilitation is more effective, and it is feasible also for nurses and other in the ward and home. So, and if you see the recommendation by American Stroke Association, they mainly recommend that for ADL, therapy must be based on functional. It should be appropriately challenging, and there should be that therapy should allow repeated practice. And the training of ADLs and instrumented ADL, they have recommended, both have class 1 recommendation. CIMT for adequate activation have class 2A recommendation, robotic therapy, and NMES have for more moderate to severe cases, class 2A, mental practice and strengthening, class 2A recommendation, bilateral training, class 2B recommendation. If you see for motor impairment, there is no superiority of any specific approaches in neurorehabilitation such as NDT, Bovath, Bunstone, PNF has not been established. So we should, finally, we should use it or lose it. And our therapy should be task-oriented, goal-oriented, and that should be, repetition is important. Thank you very much.
Thank you, Dr. Sandeep. That was a good, you took us all through all the neurophysiological approaches. The floor is open for questions. Any questions from the audience? Thank you, Dr. Sandeep.
Thank you, sir. Thank you.
So our next speaker will be taking us on a journey into what's new in the advances in neurorehabilitation. We welcome Dr. Abhishek Srivastava, Senior Consultant, Gokulaben Hospital, Mumbai.
Good afternoon, friends. Thank you, Chairperson, for the introduction. It's a big topic. I will cover in 13 minutes' time if possible. See these scans, people with very bad brain injury or intracranial hemorrhage or strokes, how do you think they are at 1 year post-strokes or post-injury? So when the ICU or home care, I show you how they are if you use advances of neuro rehab to help them better. Can we change the brain? We were told it's not possible in studying medicine. Now there is enough evidence to show brain can change in response to a stimulus. Our job in rehab is to make that change to happen. What has changed in the last 20 years? All these things have changed, which have made a difference. We'll short one by one. Some basic facts, what we all know. Neurological recovery is of two types. One is swelling comes down, changes will improve in 3 to 6 months' time. This can also be modified now by new interventions. Second is functional recovery, primarily based on rehab, also can be modified new interventions. Same way, neurological rehab is of two types, remediational rehab and compensational rehab. You can't walk, you give a stick, compensation, nothing new in that. But can you minimize the impairment after stroke or brain injury? That is what the current topic is. See example of a person with stroke, an infarct, we have a penumbra, we thrombolize to reduce the clot burden, we remove the clot, we all know that stuff, first 8 to 10 hours is possible. But in India, 3% of patients in hospital after stroke for these procedures. It's primarily rehab. Also, there are some medications you start very, very early, can improve function after stroke or brain injury. But what happens in the first few weeks and first few months after TBI or stroke is brain recruit additional area to perform new function, or other part of brain takes over function. This ability of brain to change in response to a stimulus is called neuroplasticity. What are doing in rehab is primarily treating that plasticity. It happens in two ways. You can do intensive training, something told about task-specific training. That will called experience-dependent plasticity, or second, newer treatment like drugs, neuromodulation, or robotics, which can cause further change. New concept second is continuum of care concept. We have ICUs, we have intensive care units, we have stroke units, we have inpatient rehab. Very few settings have a full content setup. We should be able to provide in our own hospital full concept. Patient who is neurologically unstable is in the intensive care unit, neurologically stable, has tubes, go to HDU, tubes are removed, go to inpatient rehab. He can take some steps now, daycare, he can take care of himself, might remember home care program. You have to provide all this in the hospital to provide a better quality for your patients in long term. Second, third is team model. My model of care doesn't work in rehab. Should first you have a full team possible, nurses, physical therapists, occupational therapists, speech pathologists, psychologists, social workers, orthotists, nutritionists, neurologists, neurosurgeons with us are a part of a team which works towards the patient. On these two models of care, at least either a pyramid or a matrix model are important in our settings. Then, what is the prescription? What we should know as a rehab physician providing patients with stroke and brain injury care? First 5 things. We should be able to provide continuity of medical care to these patients. They have diabetes, they have hypertension, hyponatremia, infections, tubes. Second, we should be able to prevent and treat medical complications, contractures, pressure ulcers, aspiration pneumonia, spasticity, sleep, pain, so on. Third, provide them training for sensory-motor deficits. Fourth, training for cognitive, communicative, and social deficits. And fifth, provide psychological and social care. If you're able to train ourselves in all these 5 things, then you can run a successful neuro rehab program to help your patients. If you can do that, you can make all these things with help of a therapy team to help your patients. Next we say is intensive therapy concept. We call it 666 in our hospital. Our patients get therapy 6 times a day, 6 times a week for at least 6 weeks. The golden period for rehab in first few months use the opportunity to provide an intensive therapy to these patients. Then you want to start some drugs. We go to ICU, wow, I got a reference. Before starting a medication, always look for these things. These are detrimental drugs. They destroy brain function. Remove them or shift to better alternatives. Also, amantadine is being approved in an NEJM article to improve function after TBI. Start the person with DOCs as soon as possible if patient doesn't have seizures. And then what's coming in a big way is HBOT, which can reduce brain edema, improve cerebral pressure, perfusion pressure, inhibit apoptosis. One of our studies we have shown in patients with severe brain injuries and severe stroke and decompression surgeries, 2/3 of patients were at GOS level 3 or more than 3 at discharge. We also know we have more sicker people coming into rehab, more older people with simultaneous CKD, CLD, advanced interventions. So these patients will have a lot of medical complications. And mortality acceptable is less than 3% in inpatient rehab, transfer back to ICU less than 5%. Should be able to provide these goals for your patients. And pick up all these complications. It's a big list. Be able to identify them, help to treat them, so the patient can go for rehab. If it's these complications, he can't go for therapy, you're missing the time, the opportunity. Then technology is helping us. We used to do ultrasound, we used to do toxin injections earlier with anatomy. Now use USG, you would E-stim or EMG, what you are trained for, it helps your patients. And don't forget the bladder. We have shown 80% of patients with stroke at discharge and neurogenic bladder. So at least do a PVR before they are sent home. We forget cognition, focus only on mobility. People have supernumerary phantom limb, people have depression after stroke and brain injuries. Simple tests available. MMSE is not enough for stroke and TBI. At least use a MOCA scale or a ACE test, 2 are commonly used. They also cognitive rehab concepts coming now. You have a trained psychologist in your team, which you can start cognitive retraining. Medication also helps, especially donepezil and rivastigmine in people with memory deficits. Depression, analysis says that paroxetine is now most safest for patients with stroke, and duloxetine has rapid oxygen action. So start these medications early. People have death depression, better participation in rehab, better outcome. Aphasia, speech therapy is not enough. Other things are also possible. But one thing for Cochrane review, that trained caregiver provided speech language therapy is equally good in long term. To train the caregiver, meet them 7-15 days, give next level of training, they can impart into the patient, it works equally in long term. Also, music therapy is now coming in a big way, along with MIT, in patients with aphasia. And medications, yes, donepezil works very well in sensory and Wernicke's aphasia, and memantine works very well in motor aphasia. You can start these drugs 5 mg OD and go to 20 mg if possible. Dysphagia, there's a GUS test, we know all that, to screen these patients. We have our own format now to be able to screen their oral function, pharyngeal phase, esophageal phase, and then start solotherapy techniques. We need trained solotherapists for that. But proper decannulation protocols are very, very important. Don't be afraid of tracheostomy. You can easily manage them. Do a simple dye test, give colored liquid, check it's coming in suction or not. If it's not coming, deflate the cuff. Put a simple valve called as pacemaker valve. People can speak with tracheostomy, people can eat with tracheostomy, both are possible. If you can do that, gradually increase the time, and all our x-rays have fluoroscopy units. Do simple test called as swallow study. You can see where food is going. If it goes straight in the esophagus, comes in front, it's aspiration. And then people with posterior circulation stroke, there's something called a vital stem, a device to improve swallow function in these patients. Technology helping us in not only in motor, also in speech and swallow systems also. There's a fixed protocol available now for decannulation in most of your patients. Follow the simple protocol, indicated all your patients successfully. Even GCS 8, you can decannulate, follow this protocol. Sensory motor function, when to mobilize. So early verticality is very important. Second day, you can mobilize any stroke patient out of bed, no problems. You can see nice guidelines not to mobilize it out and only. We spoke about the different approaches. We all know that. Are there any drugs for pharmacotherapy to improve motor recovery? There are 4 big trials. A FLAME trial, fluoxetine, has failed in long-term study in acute stroke. DAS trial, dopamine in chronic stroke, has also failed. Talos trial has showed citalopram. It's now being approved by European Academy of Neurology to start 20 mg of citalopram in all stroke patients with severe involvement to improve motor recovery. It's approved now. This is also approved. CAST trial has approved cebulicin, mainly for hand function. These 2 drugs are approved by European Academy of Neurology to help motor recovery for your stroke patients. Now, beyond that, multiple technologies have come in the last 20 years which can help. Most commonly are lower limb robotic systems. Different types of robotic systems are available now. Most commonly used is Locomat, which is a bodyweight support system on treadmill. You can start this training, and what does the Cochrane review say is that every 5th dependency in stroke can be useful, avoided if you have these patients on Locomat training. This is only useful for non-ambulatory stroke patients. Don't use Locomat for ambulatory stroke patients. Only for non-ambulatory patients. Same with opposite robotic systems. Multiple have come, anti-factor, only for wrist, only for hand, only for shoulder. All technologies are available now. We have 3 systems called as Armio Concept. We have Armio Power, Spring, and Nemedio for shoulder, elbow, and hand function. Cochrane review says that it helps these patients with stroke improving the ADL and hand function. Those who can walk want to walk better, analyze their gait in gait analysis laboratory, train them in a balance system to walk even better. We have published long back. It helps in stroke and TBI patients. FES, useful for distal, mainly for ankle movements. EMG biofeedback, useful for wrist and ankle movements. Virtual reality is the in thing now. Cochrane review says that it mainly improves hand function and the walking speed at present. Circuit training, underutilized thing, like a gym concept, train them for endurance training, strength training, works very well in the inpatient setting and the outpatient setting, helps you improve the function. CIMT, we spoke about that. Mental practice, you all rehearse our talks, rehearse your task before going for any therapy session. Mirror therapy, very useful for motor function and neglect. Adjunct to rehab. Also remember, we are physicians.